Dr. Ritvik S. Kashyap. He is an associate professor and the head of department of clinical psychology at JSS Medical College and JSS Hospital. He holds a PhD from the university at Mysore and an MPhil in clinical psychology from Osmania University. His interests include mental health and resilience, parenting styles, and child and adolescent mental health. He serves as an honorary treasurer of the Clinical Psychology Society of India and has received several accolades, including the University of Mysore Gold Medal, the COVID Warrior Award, and recognition in multiple world record listings for his contributions to mental health promotion. We're privileged to have him with us today. Sir, ma'am, if you could please come to the dais. I would now like to request Dr. Sonia Puar, Associate Professor, Amet University, to felicitate our esteemed chairpersons. I would like to invite our first presenter, Ms. Sadaf Amreen Sanyal, for her presentation.
Good morning. Good morning to one and all present here. Sir, may I? Okay. So my name is Ms. Sadaf Amreen Sayed, and my topic is Bridging Psychology and Theology. It is an integrated review paper of childhood religious trauma towards a psycho-spiritual model of care. So beginning with a short introduction. So as Indians, we have a lot of emphasis on religion, and we see religion as a source of meaning and support. So it provides us guidance, it provides belonging, resilience, and we turn to religion when in times of despair, and we think that we find solace in religion. But sometimes that same religion can also provide harm. So when doctrines, hierarchies, or rituals, sometimes when they justify doing things, coercion, violence, or neglect, it can cause real psychological harm to a person. And religion related childhood abuse and spiritual trauma, it shapes the identity and well being of the individual for their entire lives going ahead. So, as we all know, childhood trauma in general is a big determinant of psychopathology in adulthood. So, it leads to a lot of problems such as anxiety, depression, PTSD, and a lot of such symptoms. This childhood trauma or abuse, when mixed with a religious component added to it, kind of creates something known as a double layered wound. So there's abuse happening, there's trauma happening, and that really shapes a person in a very negative manner. It causes a lot of insecurities, and a person really feels betrayed by their moral and theological values which are there. Now, coming to some conceptual foundations that are behind childhood and spiritual religious abuse. We know, as I have just said, the nature of childhood trauma is that any kind of abuse, neglect, or trauma in the childhood can lead to a person experiencing symptoms of depression, anxiety, trauma, other kinds of symptoms, attachment issues going in adulthood. Now, religious trauma can be defined as any kind of abuse or trauma which occurs to an individual in childhood, which is justified in the name of religion, or abuse which is done in the name of religion, right? And religion or spiritual anything. So it can be done by family members or even the religious leaders who are there. So it has a lot of psychological and neurobiological impact. I have just mentioned a few psychological impacts in brief, but neurobiological impacts can include a disruption of our HPA axis. It can lead to enlargement of amygdala, shrinking of hippocampus. So all of which really disrupts a person's basically how they regulate their emotions. So basically, it leads to emotional dysregulation. Now, childhood religious abuse and spiritual abuse, it has its own cognitive and moral consequences as well. So trauma, as we all know, leads to a lot of cognitive distortions and thinking patterns which are really negative in nature. So trauma which occurs in a religious context also leads to the same kinds of consequences, where a person feels really betrayed by someone who they thought were their attachment figures. So sometimes we see our religious leaders also as attachment figures. So our attachment theory also somehow comes here. Double layered wound, I already spoke about how trauma and religious abuse combined can have an effect on a person's personality, insecurities, and other things. Also, there are cultural and institutional reinforcements as well. So sometimes religious leaders or even family members or community in general, they justify abuse. They encourage a person to stay silent and not speak up, to not go against what the elders are saying or what the religious pastoral leaders are saying, and that silence is basically encouraged, uh, so that it is seen as a divine intervention, or maybe the guilt is instilled in a person कि if you say something bad, God is going to punish you, or God is going to be angry on you. So all of these really shapes how a person feels about spirituality and religiosity in general. Now, when we talk about mechanism that links trauma, faith, and psychopathology, there are three main attachment. First one is attachment rupture and loss of safety. So basically, what happens is childhood religious abuse. It disrupts the formation of secure internal working mechanisms. This happens in regular abuse as well. Okay, when a person is abused or they go through some kind of a trauma in their childhood, it disrupts their attachment styles and how they function internally, how they view their world, how they trust their relationships, and how they form the relationships as well. So, as I have already mentioned, pastoral figures function as attachment figure. And when there is abuse which is done by or justified by pastoral figures, it leads to something known as an identity wound. So, here, identity wound is basically when a person is not sure about how they stand with their relationship with their God or a spiritual being or a higher power. And there are these really identity confusions as to what they should do. Should they listen to what the pastors are saying, what the community is saying, or should they, give emphasis to their own feelings and how the trauma have shaped them? The second mechanism is shame, guilt, and moral disorientation. So, moralized shame. So, a person, when they try to speak up, they are usually, being shut down in the name of morals and values. So, this leads to shame, and that shame leads to anxiety, depression, and even dissociation, amongst other problems. It leads to negative religious coping. So, here a person may turn away from religion altogether, or they may just they may be fearful of their religion or of their god, and their thinking of a spiritual and higher being would be really distorted. And it aligns with the concept of moral injury. So our chief guest at the very beginning of our this conference spoke about moral injury. It is a concept basically of military psychology, but here a moral injury is where there is a dissonance between what a person what their values are and what is expected of them or what happens to them. So that kind of creates a moral injury in these circumstances as well. Now, the third mechanism is existential collapse and the shattering of meaning. So, obviously, when a person from their childhood are encouraged to view religion as something, that they should be attached to, something they should really look forward to, and then that person is abused in this name of that same religion, it really causes a lot of questions to come up. A lot of existentialism is seen here, where they question what their purpose is, what they're doing in life, how to navigate the situations that they are led to. They experience lot of loss of faith. there is a lot of dilemma between devotion and rage towards God. So that devotion is somewhere still there. They still feel connected to that God, but in the face of all of these abuse and trauma, there is also a kind of rage or anger. Okay, if this God loves me, why is this happening to me in the name of the same God? So it generates a cognitive dissonance. Now, there are socio-cultural and institutional dimensions as well when we are talking about this. There are four things to look at here. First is cultural embedding of trauma. So, abuse, when it is reframed as discipline or divine testing, it can really reinforce a lot of negative experiences and, test a person's endurance, which is there. Also, there is an intergenerational transmission which occurs when we are talking about childhood religious abuse. So individuals who have gone through abuse in their childhood, they grow up and then, intentionally or unintentionally, they end up causing the same abuse to their own kids or to the others in the society. So there's this kind of intergenerational trauma also when we are talking about this. And then there is institutional betrayal and abuse of conscience. So, spiritual abuse of conscience is where a person is really not encouraged to speak up against or show any dissent towards the spiritual leaders or the pastors. And somehow, in certain aspects, there is a manipulation of believers' moral reasoning to maintain obedience. So, individuals are really roped into this behavior. Okay, you have to be obedient no matter what, otherwise, there will be negative consequences. You'll go to hell, or God will be angry at you, or things will not go right in your life. We have all heard such kinds of statements from many people around us. Also, there is a kind of institutional betrayal. So, when there is a prioritization of reputation. Sure, sure, sir. So, I'll quickly wrap it up. So, there is betrayal from the institutions as well. There is patriarchy and theological control. So, here we are talking about submission, how women and children, especially, are expected to submit to higher authorities and basically the leaders. Now, psychopathological and neurobiological outcomes, I have already briefly spoken about it, so I'm just going to skip over it. Now, when we're talking about reconstruction, the therapy or the interventions involve basically reshaping a person's view of trauma to, re-experiencing those emotions in a safer environment so that they rebuild that relationship with spirituality or religiosity. So it involves basically integration of psychological and theological models. So here, when we talk about integrating clinical and theological healing, basically psychologists and spiritual leaders can come together, psychoeducate each other, and help our society to or individuals to deal with the trauma or abuse that they have been through. And we can also, going ahead, we can also make sure that these kinds of abuse does not happen in the future, or we can look at how the ways to prevent such kinds of abuse. So, this is what I have spoken just in brief. So, yeah, I think my time is up. These are my references. Thank you.
Thank you. I will look at these questions. Now that answers. Related to talking the way that when you talk about nationalism, we talk about monarchy, then we talk about religion. In India, there are multiple layers to this particular concept.
Definitely.
Because with the colonial past that we have, the concept of religion is quite different from the concept of religion in the West.
Definitely.
My problem with this is because I'm dealing with my own students who come from this background. Students who have come, who have had a childhood in the Gulf and then come to India, and then people who are born and raised in India. Their theologically frameworks are quite different.
Definitely.
So how do you intend to, because this is therapeutic that you're looking at, so how do you intend to look at it?
Right. So I think what the way that I would look at this is not from a lens of the kind of upbringing that they have had in India or abroad, but the kind of experiences they've had, right? And what impact those experiences have on their own personality, of their own thinking, and how they view spirituality. So, if their spirituality is harmed in some way, if they have been abused in some way in the name of religion, how we can navigate towards that. So I understand that there are a lot of differences when we are talking about the Western concepts and Indian concepts, and even in India there are so many religions. So those also differ from one religion to another religion, culture to culture. So I think this was a very basic level of a study, and I'm planning to build up on that to understand exactly how. Religious trauma, especially in the Indian subcontinent, it affects a person's psyche in general, and how we can move towards creating a psycho-spiritual model of care. So I think that is what I hope I've answered your question.
Any other queries from the participants?
You said that it's a review study. So what was how many reviews in the study you could actually find on spirituality or religious trauma relating to religious abuse? If it's a review study, you must have taken a lot of scientific
Yes.
studies.
Yes.
So what is your total number of review papers that you have actually seen, and the meta-analysis of what researches you have gone through? Or building up on emotional trauma and religion trauma.
Right. So, ma'am, most of the studies have been done in the Western areas. I have found some studies in the Indian context and in Asian context in general, but there are not a lot of studies. So,
If you can name any, let's say, you know, you build up your review. You see, you lot of meta-analysis.
yes.
When you do review, you do a lot of meta-analysis of the researchers that have been done. So, from that context, if you can relate some new narratives of emotional or religious trauma or faith trauma that you have seen in the Indian context and in the Indian culture prevalent, if you can answer now.
Okay, right. So, some of the studies that I have been through, they talk about how spirituality is damaged. So, I personally have seen as well, and I have read in a certain studies that individuals they end up, you know, fearing God, but not in a healthy way that we have been taught to. So that fear of God is there, and there is a lot of anger towards God, and then that creates a lot of cognitive dissonance in the person's own mind. Okay, how they are supposed to view God and how they are supposed to navigate towards navigate spirituality and religiosity in general. So there's a lot of emotional dilemma which is there. Okay, am I supposed to be devoted to this God, or am I supposed to just fear this God? Am I supposed to love him, or am I supposed to fear his wrath of hell, or any other things which are there? So a lot of emotional is there. A lot of PTSD symptoms are also have been shown in certain studies. Okay, since these kinds of trauma, it is not one single event that causes this. It's a lot of small scattered events which happen throughout a time. So a lot of the symptoms imitate what our PTSD looks like. So, yeah.
Thank you, Sudhaf. That's wonderful work that you have initiated. So while we appreciate the conceptual clarity and also the derivatives that you are able to present here, we also see that the methodological perspective. So what is it that is leading to these kind of understandings or these findings? So how many articles, because you are presenting it as an integrated review. Okay, so how many articles you were able to look into these kind of a things, or what is the methodology that you're following for this particular review is missing in your presentation? Okay, so that is something that needs to be taken care of. Thank you.
Thank you, sir.
I would now like to call upon our next presenter, Ms. Kirtana.
So request the presenters to keep up to the time. So you have 8 minutes for presentation and 2 minutes for Q&A.
Good morning, all. I'm Keertana, and I'm studying second MSc Psychology with clinical specialization program from Katil Ashok Pai Memorial College, Shivamogga, which is affiliated to Coimbatore University, Karnataka. And today I'll be presenting my research that was done for my dissertation, a comparative embedded study of family dynamics and exploring its role in social cognition among men with schizophrenia and men with alcohol dependency syndrome. And my guide for this research is Dr. Archana Bhatt K. A brief introduction. The study is about how family dynamics could contribute to social cognition and the comparison of social cognition among men with schizophrenia and alcohol dependency. Using only qualitative or quantitative approaches might not be sufficient. Hence, an embedded design is used where family dynamics in rural Indian caregiving settings are collected as qualitative data and are analyzed using thematic analysis. And 3 tasks are administered to the patient to assess social cognition quantitatively. This integration allows for a richer contextual, grounded understanding of the cognitive and familial dimensions influencing schizophrenia and alcohol dependency in the Indian context. Men were selected for the study because there is a higher rate of alcohol dependency seen among men. So, a brief background. Uh, Before I began the work for my dissertation, I was curious about the concept of theory of mind and wanted to explore something related to that. And when I looked for papers in general, what I observed was in the Western papers in general, they have mentioned that there is deficits in social cognition among men, persons with schizophrenia. So this kept me thinking because when it comes to the cultural and family systems or the social interactions during illness, when compared to the West and East, the family dynamics is very different. The way the patients are treated are very different. So, in Indian context, no matter how much the caregiver burden is present, the patient stays with the family. There are certain level of normal activities happening in the family, right? And we can also say that, especially in the rural Indian context, that if a patient is admitted to the hospital, there are a number of caregivers and family members coming and visiting the patients. So this is the reason why I chose the concept of family dynamics. And there's also a role of religion and cultural practices and local belief systems that could contribute. So these are the operational definitions. Family dynamics refers to the patterns or interactions among relatives, their roles in relationships, and various factors that shape their interactions. Social cognition is cognition in which people perceive, think about, interpret, categorize, and judge their own social behaviors and of those of others. Emotional recognition, being able to detect, process, and respond appropriatively to the emotions of others, is crucial for normal social interaction. Impulsivity or impulsive behavior is broadly defined as actions without foresight that are poorly conceived, prematurely expressed, unnecessarily risky, and inappropriate to the situation. Impulsivity is associated with undesirable rather than desirable outcomes. And the embedded study, first described by Caraselli and Green, is characterized by having one dominant method, whereas the other data sets provide a secondary or supportive role. So the main rationale of the study aim is to explore social cultural aspects of family dynamics and not to provide definite answers. Instead, gain a deeper understanding of it and identify areas for further investigation. This can uncover new possibilities, highlight areas for further study, concentrating on family dynamics as one of the contributing factors for the depletion or sustenance of social cognition among men with schizophrenia and/or alcohol dependency. Additionally, by comparing social cognition scores with men with alcohol dependency syndrome, the study will offer a comparative perspective. This also sets the stage for more structured research projects in the future. So these are the reviews that I would want to present. There's a study that was conducted in 2013, conceptual framework that expands the understanding of social cognition and schizophrenia by emphasizing the interactive dimensions of social processes rather than considering social cognition as an isolated function. And then there was another study in the year, this was from a book in 2007. The study of the manner in which psychosis was perceived in different cultures showed that Indian patients diagnosed with schizophrenia were described by family members as manifesting a more affective and self-centered orientation. And another study in the year 2020 offers a theoretical framework and proposes future research directions concerning the interplay between social cognition and problematic alcohol use. So this was the methodology. Inclusion criteria, men with ADS, age 25 to 40, men with schizophrenia, age 40, informants of the patients. And exclusion criteria were ADS and schizophrenic men with comorbidities. And then study setting was Manasa Nursing Home, Shivamogga, and A.V. Baliga Memorial Hospital, Udupi. The sample size is 20, sampling method is purposive, and the tools used were pictorial measure of social cognitive ability by Kiran Kumar and Archana Kalahala, one of the authors being my guide. So this study was initially structured or created for children. So it was a children-based social cognitive ability test. But interestingly, the cards that are of the test, it kept me thinking that it could be used for adults as well. So we did a pilot study to check if it can be used on adults. And among the 10 cards that are used in the test, we chose 6 cards that could be appropriate for using on adults. And then we've used the reading mind through eyes test and another picture response test for assessing impulsivity. Qualitative data, semi-structured interview for family dynamics and socio-demographic details. All the ethical clearances sorted. So this is the justification of sample size. This is majorly qualitative study with a concept of quantitative in it. So initially we had the sample size of 65, and because there was a screening process that had to be done for the level of insight to be checked. So with the help of a clinical psychologist, MMSC is conducted, among which 15 were excluded and 45 were included. And among those 45 data collection, there were 25 dropouts. Dropouts here, I mean to say that either the data weren't as accurate as required, or the patients weren't agreeing to continue with the tests, or it could be that they have the family who had come initially for the patient's admission or anything, the same family caregivers haven't come the next time when I had to proceed with the family. Those are the dropouts. And then the final data analysis was conducted on 20 participants. So this is how my study is structured. So embedded study, majorly qualitative, that is family dynamics, and there's a quantitative data available as well, and together the interpretation has been conducted. So these are the themes that I've addressed in family dynamics: religion, security, caregiver burden, economic, marital impact, children, social stigma, gender, religion, communication, family demographic details, and patient's childhood. These are the key differences that I have found according to the themes among the two categories of patients that I've looked at. So the key differences when it comes to family conflict is that ADS conflicts often revolve around money and alcohol expenses, while schizophrenia conflicts stem from delusions and loss of person's former self. And caregiver burden in ADS, mothers are the main caregivers. In social cognition, sisters often take an active caregiving role alongside mothers. Economic impact, ADS drains finances mainly through spending on alcohol and treatment, while schizophrenia impacts income due to loss of work and long-term care demands.
You have 1 minute to wind up.
Sure. So these are the other key differences. Now, majorly speaking of the outliers, I looked at the scores, high and low scores, scored among each category. So ADS patients, we can see a hypothesized connection between their social cognition and the family dynamics. So high scores indicated stable family support and caregiver resilience that could contribute to social cognition, and in low, dysfunctional dynamics and impaired social cognition and marital breakdown. And then there's all in among schizophrenia patients, um, the high scores, the hypothesized connection could be the family cohesion and advocacy and high premorbid functioning, and low scores could be childhood trauma and emotional suppression. So this is what I actually wanted to emphasize most on. So on the blue and green indicates blue indicates lower social cognition, green indicates higher social cognition, and the orange one indicates neutral or average. So these are the few factors I found during family dynamics that the data I've collected from family dynamics, and I just want, because this was interesting, I just wanted to present it here. So among the patients with schizophrenia, we can see that the ones with low social cognition and the scores in the test, they had seen to be visiting more temples, and on the other hand, the patients with higher social cognition ADS, so they are seen to be visiting temples more in the aspect of, you know, helping for the cure. And then when it comes to financial strain because of illness, among ADS patients, the social cognition is high. The ones who have high social cognition, they have a financial strain. And there are high scores in both schizophrenia and ADS. These people have income depletion. This is common. And we can see aggression in patients with schizophrenia who have low social cognition. We can see medical non-adherence as well in low social cognition with schizophrenia. And pre-morbid academic success, there's a whoever scored higher in higher scores in social cognition among patients with schizophrenia, they had pre-morbid academic success. Likewise, for trauma and job loss, there's a drop. Like people who have low social cognition schizophrenia have experienced trauma and a job loss as well. And then pure rejection among men with schizophrenia is seen with patients who have low social cognition. And high social cognition among patients with ADS, peer influence among men with alcohol dependency syndrome is seen.
Please wind up.
Yes. And this was among caregivers. These are the discussions. Thank you. Yes. This is the discussion, scope and limitation, differences.
Thank you. And the floor is open for questions. No questions?
So you said that you have taken, although it's a good study, but you have taken schizophrenia and ADS together.
Right.
What are the common features that you think that will be contributing to the study? Because you're studying the family dynamics
Right.
and its social cognition,
Right.
and you have taken two different disorders
Yes.
altogether.
Yes.
What were the commonalities and why? What was the requirement of comparing two different disorders? Why not like schizophrenia, social dynamics, and alcohol,
Right.
dependence? So my first question is this.
Yes, ma'am. One, among the literature reviews that I have studied for the dissertation, I did find that there were studies separately conducted on patients with alcohol dependency and separately conducted on patients with schizophrenia. That was one of the reasons why I wanted to compare the two populations, one thing. And another thing is that I wanted to provide a comparative analysis. So I did initially think, and among patients of alcohol dependency syndrome, when they're induced with alcohol, there are symptoms of like psychosis seen only when induced with alcohol, right? So that comparison.
So you have taken those subjects as
No.
as your subjects?
No.
No comorbidity with
No.
schizophrenia.
No.
So what was the reason? Like what newer insight it will give like two different disorders altogether? See, there has to be some scientific implication.
Right.
Think of it. Then you should be able to find it out. Now you read more on this. That you've taken two different disorders.
Yes.
One cannot answer, I want to. I want to, it's a good thing. It's
Yes.
actually a good thing.
Yes.
But then what common features, what it will add a newer insight to the research is more
Right.
important, right?
Right.
And another question mine is, you have said you've used a qualitative study,
Yes.
right? What qualitative study? What the method? There are so many of qualitative study. So what was the method of your qualitative study?
So it was an interview, and I have used embedded study analysis, thematic analysis, ma'am. Thematic
You
analysis.
took the thematic analysis. Okay.
It was a caregiver burden that we saw that it was present in both. And we also saw that they were incurring heavy financial losses. And in spite of being an integral part of the family, the background was more or less similar when it came to institutionalization. So that was one thing that we wanted to see, because the main theme was the social cultural factors and the caregiver burden also, which was involved. So that was the main reason we just wanted to see. Also, from here to construct further, if we see something here, then we will go ahead with pure schizophrenia. So that is something that we wanted to see. It was predominantly the caregiver burden and the family dynamics that we were looking at.
So while I agree with your conceptual clarity, ma'am, so the family dynamics and the caregiver burden, that is something that can be falling in line. But why social cognition being brought up as additional variable while we are comparing these two conditions?
Right. So, as we can see, there's a lot of social context being involved in the Indian context, right? Like the way we function is quite different. Like the family functioning is different. The way we are, accepting the viewpoints, the perspectives, everything becomes different, right? So, social cognition is something like I felt that family dynamics could significantly contribute to social cognition of an individual, right? So that is the reason we chose social cognition as the quantitative part of the test.
Kitana, can you tell me in one line what is it that is your research finding that you were not expecting?
I was not expecting. Right. So one thing that I clearly found was that among patients with ADS, the caregivers have a problem with the patients itself. And among patients with schizophrenia, they have a problem with the disorder and not the patient. So no matter how much caregiver burden they experience, they still stay with the patient and take care of them. So this is one of the major findings that I found in the study.
Thank you.
Thank you.
I would now like to call upon our next presenter, Mr. Abudhay Bhargav.
Yesterday in the special category. In the special category. Um, Good morning, members of the panel and members of the audience. The title of my presentation is Effectiveness of Indigenous Model of Intervention on Reducing Distress Among Personnel Involved in Counter-Insurgency Operation. It is a pilot study which is part of my PhD thesis. So briefly going over the introduction and the review of literature. So India's counterinsurgency forces have evolved over decades in response to various separatist movements in Kashmir, Northeast, and Maoist affected regions. The troops serving in these regions have various challenges in terms of psychological stress, mainly because of isolation from the family, financial problems, their work schedule, which is not structured, as well as their operational stress that they go through. Now, the military have taken various steps to mitigate these problems, but at the same time, due to stigma as well as lack of accessibility to these resources, these problems still persist in these troops. Even indigenous approaches like yoga, vipassana, mindfulness have been adopted by the military to help these people. But again, there is no structured, sustainable intervention that has been implemented or is present for these troops. So this present study introduces a structured intervention module aimed at reducing psychological distress among these counter-insurgency groups. Um, Going quickly with a review of literature, I found out that there were many psychological problems such as anxiety, depression, PTSD, alcohol dependence, as well as adjustment issues that were present among these troops, mainly stemming from isolation from the family, irregular schedules, and constant operational demands. Stigma was the major barrier due to which these problems still persist among these troops. Indian traditions such as yogas, Vedas, Bhagavad Gita, Upanishads provide a culturally grounded model for mental health, emphasizing emotional regulation and cognitive restructuring. So Vedic mantra practices, Upanishad practices like self-inquiry, mind control are different ways by which they can, become more adaptive and improve their coping mechanisms as well as resilience. Now, these approaches they parallel traditional mindfulness practices, but at the same time provide a culturally accepted way for these military personnel to adopt these interventions. There's a growing recognition of these indigenous practice, especially improving mental health in the military perspective, which shows a shift towards culturally relevant interventions. Despite the efforts by the military to incorporate these practices in their normal schedule, there are a lot of problems because there's no systematic incorporation of these indigenous therapeutic systems. So this highlights the present need for a culturally appropriate intervention supported by holistic assessments and research to strengthen mental health care for the military personnel. So the aim to measure the effectiveness of an indigenous model of intervention in decreasing psychological distress in troops posted in counter-insurgency areas. The objectives of the study was to develop such a structured indigenous module of intervention as well as to check its effectiveness on the troops posted in counter-insurgency areas. The hypothesis was there will be a significant reduction in psychological distress levels before and after the intervention, and that the intervention itself will have a significant effect on the psychological distress experienced by these troops. The sample consisted of 30 individuals who was so initially 100 troops were selected. They were screened using depression, anxiety, and stress scale. The individuals showing mild to moderate stress, anxiety, and depression were only included in the study. Inclusion criteria: the age range was from 18 to 45 years, and those who were willing and were available for the intervention were included in the study. However, people who were outside of the age range were not included in the study, and those was not available or willing to attend these sessions were also excluded from the study. At the same time, people with severe mental illnesses or physical illnesses were also not included in the study. The tools basically used were HAM-A, BDI, SWLS, which is satisfaction with life scale, WHO quality of life scale, and RIF psychological well-being scale in the pre-test and post-test analysis. The intervention draws inspiration from the medicine wheel, which is a fundamental indigenous symbol representing holistic health and healing. It has been used widely for years in the North American indigenous cultures. The medicine wheel, as you can see on the screen, is divided into 4 parts. They represent either the four cardinal directions, but they can also represent the various aspects of a person's mental health. or psychological well-being, including the physical, emotional, mental, and the spiritual aspects. Now, based on this approach, practices from yoga, Ayurveda, Buddhism were integrated into a structured program for intervention. The program consists of 12 sessions, each lasting about 45 to 60 minutes. The sessions were conducted 3 times a week, resulting in a month-long intervention period. The procedure, a quasi experimental design that included a pre-test and a post-test, was implemented for the purpose of this research. Participants' level of anxiety, depression, and psychological well-being were compared and analyzed pre and post the intervention. Statistical analysis was done using SPSS as well as Excel. Both descriptive and inferential statistics were used. Due to it fitting the criteria of normality, paired sample t-test was used, and to calculate the effect sizes, Cohen's d was utilized. The research also shows links between indices of distress and well-being, for which Pearson's correlation coefficient was used. I have included the result tables at the end of the presentation, but I'll quickly go over the major result findings. So initially, the descriptive statistics showed that higher levels of anxiety and depression were present with HAM-A BDI score in the mild to moderate range. After the intervention, most of these scores on depressive and anxiety scales reduced significantly, as well as those of psychological well-being showed significant improvement. Even the effect sizes were found to be moderate to substantial, confirming that the intervention was not only statistically but also practically effective. Overall, we can see that this indigenous program successfully decreased psychological distress and enhanced well-being among inter-constituency persons. Now, additional findings were there also. So prior to the intervention, there were negative associations between life satisfaction and well-being, and also depression and anxiety were highly correlated. However, so showing that distress variables had the greatest impact in lowering life satisfaction and psychological well-being. Post-test correlations revealed substantial changes after the intervention. Life satisfaction became less influenced by distress, while positive associations strengthened among well-being measures. Negative associations between psychological health and social environmental dimensions decreased, suggesting that the intervention reduced distress, fostered more adaptive, balanced relationships across various well-being characteristics. The discussion findings revealed a significant improvement in mental health and overall well-being with strong effect sizes across most of the measures. The intervention was safe, well tolerated, produced no adverse effects, and improvements were observed in autonomy, personal growth, mastery of the environment, reduced painful experiences, while resilience and coping strategies were strengthened. These results also align with previous researches on mindfulness and yoga therapies that show that such practices reduce psychological distress and enhance coping mechanisms. The study shows that such indigenous therapies, which are culturally adaptive, can effectively reduce depression and anxiety while enhancing resilience, self-control, and life satisfaction. However, there are certain limitations to the study. First, there was a small sample size. It was a single group design, pre-test and post-test design without a control group, which restricted the causal inferences and generalizability of the study. And despite these constraints, the use of validated tools and effect sizes show there is some positive findings to throw some positive light on this indigenous intervention. Now, the future research work should focus on larger randomized trial, longitudinal follow-ups, and diverse participant group to confirm these results. All in all, I would like to conclude by saying this is not a therapeutic model per se. This is more of a preventive model which aims at increasing the resilience among these troops and equipping them with coping mechanisms so that they can face such high stressful situations. These are my references. Thank you. These are the results tables that I have included in the presentation.
So floor is open for questions.
Abhuday, when you said that, there was a comment mentioned in your testing area where you said that the patients were having high anxiety and depression. Mild to moderate, you
Yes,
said,
yes.
but then also you said that higher levels of anxiety and depression. So what happened to the patients after you gave them a possible, you had a certain thing, right? You did a pre-post study. So what happened in the post? Were the mild anxiety and depression patients in the normal range?
significant areas that was shown by
So
the
there was
test.
no severe depression or severe anxiety category.
Severe depression, severe anxiety were not included in the study. Nothing with like a severe psychiatric illness or a physical illness were included in the study. The idea was to make more of a preventive model, so not a therapeutic model per se. So it would be difficult to work with people with severe mental disorders. So that
All
is
right.
not included.
Thank you.
Okay. My question to you is that, see, two things. You have taken anxiety and depression,
Yes.
right? And 30 sample size. So did you actually classify it? Who are those people having anxiety? Because it's a separate disorder, different spectrum, and depression. Or they are occurring together, because the scales that you have used is clinician rating scale, Hamilton BDI, which is a screening tool for depression and anxiety. So you mean to say that all of those 30 participants were comorbidly having both, like both anxiety and both depression, or they were different, like people having depression separately, people having anxiety differently, symptoms are different, diagnosis is different. So how is your 30 participants, you've concluded this, like those having anxiety, those having depression, because
Okay.
the scale that you have used is kind of clinicians rating scales.
So initially 100 participants were selected, and they were shortlisted on the basis of DAS, which is depression, anxiety, and stress scale. After which, in the pre-intervention, the pre-intervention phase, the testing was done where HAM and BDI were used. In most of the cases, people having at least some sort of depression also showed mild levels of anxiety. So they were a lot of times they were comorbid together, but in some cases, there were only symptoms of depression or anxiety present.
When you have already screened them based on DAS, what is the need for the additional assessment?
That was just to compare the levels pre and post. Yeah, after the intervention.
You have the DAS scores already with you,
Yes.
so which is giving you clear-cut indications, and again the subjective in
Sure, sure. I
evaluation
understand your
also have
point,
their
yeah.
conditions, and moreover you are using one as a clinician rated as a HAMI, and you are using as a like subject rated as BDI. So, and there is already another assessment that is already there. I don't see a need for this such kind of a replication of assessment. Okay. And these are our soldiers.
Yes.
Okay. And so now these kind of experiences, I mean, the things that are the items that are there as an anxiety and element, these people are trained to be more resilient. These people are trained to be much more, yeah. So would you see that this scales would be really be enough to specifically pick up their levels of anxiety and other things?
So I understand where you say that they are being trained mentally, but these groups that were included were not at the officer level, they were more of the other ranks. So other ranks are those who are directly taken into the army after their physical test. There's no psychological testing or psychological training that is given per se. So now there they have a lot of these symptoms stemming not from their operational stress, but from the family stress. Family issues, because of phone, they'll just come
It
to
is
exactly.
hard for us to really differentiate that. See,
Yeah.
when you are taking a stress evaluation,
Yes.
so ना आप ये नहीं कह सकते कि ये फैमिली वजह से आ रहा है और ये काम की वजह से आ रहा है.
So during the first session where I took the interview, where I take the relevant history, that is where they themselves reveal ki work-wise we're pretty, we are not stressed because in the field operation there's either work or we have free time. Most of them their problems arise either from family or financial strains, which is what also was one of the leading causes for the suicides that were happening in the counter-insurgency forces. So while the time I posted, there were two such cases, and the suicide notes that were left behind were either due to extramarital affairs or them unable to pay back the debt loans due to like giving them in gambling or taking loans and buying different things because of the extra allowance that they get because they're posted in the field areas.
Thank you.
Thank you.
I would now like to call upon our last participant, Ms. Mansi.
Hello and good morning all. My name is Mansi. I'm an MPhil trainee at Abhas, and I'm going to present the paper titled the experiences of highly sensitive people and interpretative phenomenological analysis with a neurodiverse approach. So, who are highly sensitive people? These people who possess the temperamental trait of sensory processing sensitivity, which is a nervous system orientation characterized by low sensory threshold and deeper processing of the stimuli which is around them. Sensory processing, you can imagine sensory processing sensitivity or people who are highly sensitive as being smoke detectors. Smoke detectors who are ultra sensitive, they can detect minimal smoke, but with an ease and with a quick nature, while also using all of their battery life or most of their battery life, which can be helpful or unhelpful. It is also important to distinguish between sensory processing sensitivity, sensory processing disorder, and difficulties. These are overlapping yet similar, yet different constructs. Now, why is this trait under question, or why do we need to study this? Sensory processing sensitivity is the bio of the biopsychosocial model. Uh, it leads to heightened arousal of the autonomic nervous system, and in stressful conditions, it can amplify stress responses. Uh, People who are highly sensitive, they have various mental as well as physical health outcomes that can be detrimental. With these physical and mental limitations, what happens is that not only their quality of life gets impacted, but also they tend to underutilize their strengths and resources, which makes them have lower self-esteem or less coherent self-concept or sense of self. They also experience stigma, shame, and social misunderstandings. There's also a dearth of Indian studies in the topic, so it needs our clinical attention for comprehensive assessment and management of the difficulties to prevent as well as manage the lack of utilization of their strengths. Review of literature. On a neurobiological level, the serotonin transporter gene has found to be implied, which affects the emotional reactivity. There's also been the implication of heightened insula and also the anterior cingulate cortex. Physically, because of the heightened arousal, these people tend to experience somatic complaints, which is known to be moderated by childhood environments. Mentally, it has been linked to negative affectivity due to the serotonin gene transporter. Uh, Alexithymia has also been known to link to sensory processing sensitivity. Socially, people who are highly sensitive, they tend to isolate themselves and withdraw themselves in the face of social stresses. But because of their strengths like innate sensitivity, the ability to be creative, or being finely attuned to their environment, they also form deeper connections, which is one of their strengths. The quality of life when they are in a chaotic environment, it tends to be low. Places like at work or at school where the environment is quite depleting, it can cause overstimulation, which predicts low quality of life. When it comes to adaptive strategies, it has been found that when HSPs tend to regulate themselves using adaptive coping strategies such as grounding or journaling, it has been linked to increased well-being. What also protects them is their inherent capability to be mindful, which is known as dispositional mindfulness, which aids the process of coping and adaptive self-regulation. Methodology. The aim was to explore the lived experiences of the individuals with the trait of sensory processing sensitivity. The objective was to understand how their quality of life is, the emotional experiences of such individuals, and the kind of self-care strategies that they use. And also to highlight the clinical significance of the trait. The study used a phenomenological research design. The tool used was the highly sensitive person scale developed by Aaron and Aaron in 1997 with a sound psychometric property. So in total, 6 participants participated in the study. They were young adults. Purposive sampling was used. The inclusion criteria was that they were screened positively before being an HSP. they were residents of India, English speaking, and they were aware of them being highly sensitive. The exclusion criteria was that they did not have any diagnosed mental health condition. So the semi-structured interviews were prepared, and in the meanwhile, uh, HSP, HSPs were identified and screened using the HSP scale, for which a Google form was prepared and spread across the internet. The participants who were also identified were contacted. They were briefed about the study. Informed consent was taken. After they were contacted, before the conduction of the interview, the semi-structured interview was shared with them 2-3 days prior to the interview. After the interview happened, it was fully transcribed for analysis. Now, we used some interpretative phenomenological analysis for the study. It required immersing the researcher into the data, into the study, reading it, rereading it, getting familiar with the data and having a dialogue with the data as well, which caused to generate meaning units. The researcher's interpretation, keeping in mind the research questions. Throughout the process, a reflexive journal was maintained. The biases, reactions, reflections were noted. This happened across cases and cross cases as well. The meaning units were clustered into superordinate and subordinate themes, and cross comparison was also done. Later, the themes were finalized, keeping in mind the research questions. The results. So there were 9 themes that were discovered throughout the process, and these 9 themes have been could be categorized into 3 segments. So segment 1 included self as a system, how a highly sensitive person builds themselves, themselves, and how their self gets affected by outer as well as inner experiences. So it basically included the awareness of their highly sensitive nature. Where was the point where they discovered that they were highly sensitive? How could they trace that back to their childhood influences? How it made their sense of authenticity quite grounded and strong, and also the drawbacks of being a highly sensitive person. It also shed light on the inner conflict of these individuals, contradicting viewpoints, emotions, being able to finally attune to their environment, sensing the needs of other people while compromising on their own needs. And because of the limited energy and limited resources, they can only cater to a limited people. And also the fact that how their boundaries were blurred, how they were unable to identify whatever discomfort that it was that they were sensing, was it their own or was it someone else's? It also shed light on the disabling nature of empathy. Despite empathy being a core strength, how it can disable the individual if they do not build firm boundaries, or if they are not able to identify the discomfort if that's their own or if it's someone else. It also shed light on the inner worlds of these individuals, the vivid imaginative aspect of their lives, which can be a safe haven for them when the physical world gets very heavy, when there is a lot of social pressure surrounding them. It also has a nurturing effect on these individuals. They rely heavily on their inner worlds for that, and how it creates this sense of narrative for them, a narration for them, which constantly goes on, which is a reaction of their outer experiences, but also their inner dialogue, which somehow helps them make sense of the world surrounding them. Now, the next segment talks about effects on mental health, social influences, and well-being. How does it affect their quality of life? So HSPs tend to have lower self-esteem, it was found. They're more prone to have ruminating thoughts, emotional suppression, and dysregulation, which can lead them into have maladaptive ways of thinking and feeling, which can manifest itself in anxiety, dissociative tendencies, or even depression. When it comes to social influences, what the HSPs undergo, it's social stigma and rejection, demands and expectations from the society, a lot of misunderstandings or being labeled as too sensitive or weak in general for their emotional reactivity. They are also a subject for manipulation tactics at times because of their heightened empathy, they tend to fall to that. The consequences are that they tend to socially isolate themselves. There's a tendency to internalize the stigma. Social anxiety is a consequence of that. Downward social comparison and a sense of being misfit in the society or wherever they are. The risk factors which can pose as a threat to their well-being could be disruption in the physical environment, prolonged exposure to stress, physical health complaints like chronic migraine or chronic pain issues, which are quite, prevalent in the HSPs, and also self-neglect. Protective factors that were found to be significant are connecting with nature, other acceptance of the person's sensitivity, their sense of ownership of their sensitivity, and also the artistic value, which is somehow a consequence of high aesthetic sensitivity as well, which is a subdomain of sensory processing sensitivity.
Please wait up in a minute.
So the next segment talks about the engagement with certain self-care and self-regulatory strategies which help the HSPs ground themselves and also let them use their strengths in various ways. So it's not just the lowering of the negative effects of their sensitivity, but also increasing their inherent strengths and making it into use. So it was found that adaptive avoidance, using grounding, emerging into flow experiences, establishing firm boundaries, having social support was found to be impacting these people positively. Now, when that happens, it also opens gates to various experiences that can be spiritual in nature. How their meaning making somehow emerges. They tend to have deeper connection and deeper meaningful experiences around them. And also how that can lead to a personal transformation for these people, where their experiences somehow gets enhanced and their view of themselves also gets enhanced. While their negative effects are lowered, they also are inclined spiritually. They also view their sensitivity as a gift, which makes them have enhanced experience, a sense of purpose. They also tend to have a leadership or a change making aspect in them because they feel everything so deeply that it just turns out that they use their strength in that direction. They also develop a coherent self concept due to that and makes them have a creative drive and acknowledge their intuition and its use. So we have discussed that sensory processing sensitivity can be a risk factor to develop various mental health conditions, and also physical health complaints can be quite prevalent with them. Also, the lived experiences of highly sensitive people are quite similar to those individuals who have autism or ADHD, basically a neurodevelopmental conditions. So, what this study tried to imply was that with the awareness of the trait, with the awareness of being a highly sensitive person, and also engaging in adaptive self care strategies, self regulatory strategies, which can increase their quality of life, they can also use their strength in various ways. So, it warrants clinical attention to have a comprehensive assessment of an HSP or of sensory processing sensitivity, because they are the minority population who make up the majority when it comes to availing the therapeutic services. So that's all from my side. Thank you. These are the references which were used.
Floor is open for questions.
See, in your study, you said that you had identified highly sensitive people.
Yes.
What is the objective criteria of identifying them? Like, how do you identify the HSPs?
So this concept was conceptualized by Aaron and Aaron, and they have developed a highly sensitive person scale, which has been cross-validated in various cultures, excluding India, though. This has not been introduced in India so far in that sense, with a psychometric sense, but there is a recent revised version of a similar scale that I have used. There's a revised version of that, but this scale is available in the public domain, which I used for the study. It has 27 items with a 7-point Likert scale. The current version, the recent version, has been published in 2024, if I'm not wrong. Yeah.
Your inclusion criteria states must be aware of being an HSP.
Yes.
So once they had been screened on the scale, did you
yes.
tell them that you're an HSP?
No, it was not I who told them. It was they who basically already knew that they were an HSP. There are individuals who are HSPs and they know that they're in HSPs. But there are people who can be highly sensitive, but they don't know that they're highly sensitive. Just like people who can be autistic but not know that they're autistic.
So what was your sampling style for this? Like what sampling method did you use for this?
Purposive sampling was used. I made a Google sheet, basically Google form, which had the highly sensitive person scale in it, that used as a screening tool for me. So
How
as
did you also identify that the people who are referring to themselves, since this was on an online domain,
Yes.
how did you manage the limitation that if I am identifying as an HSP, I'm actually an HSP?
I asked them if they knew that they were HSP. So it was self-reported only.
So
It
that
was a
is a
bug of-
limitation, right?
There is a limitation that it was
Yes.
self-reported. Yes. Yes.
In continuation with what ma'am asked, why is it necessity? I mean, why is it a necessity for them to know? Because we also see that there's over glamorization of these terms. So, and it is not necessary. Like, it's very, I am depressed is something that goes on common in everyday thought. So, this being aware of HSP is something that could be problematic, that people are sort of over glamorizing that term, is one thing that I felt. And also, you have 3 female participants. The time of the interview of the menstrual cycle also probably could be a very important factor here, because PMS is something which is, we all know sensitivity goes up. So, by any chance, have you taken that into consideration?
I could not take that into consideration, but to answer your previous part, the knowledge of being an HSP corresponded to using the phenomenological aspect of it. Until and unless the person does not know that they're aware of their own sensitivity, how can I ask about their lived experiences? For example, if I am a woman, but if I don't know that I'm a woman, how could I answer the questions related to that? So, as per the methodology, as per IPA as a tool is concerned, as per Smith, who is the proponent of it, they mentioned that the sample must be homogeneous, but they also must be aware of the construct, or their own lived experiences, their own shortcomings, their own strengths, and that's why it was used. Basically, that's why it.
I understand, Mansi. Ma'am wants to know why the need to study the lived experience of sensory processing sensitivity in people. What it will contribute to the research, how it will change any perspective. If anybody, suppose we have schizophrenia, it's a disorder, it has signs and symptoms, it needs some treatment. So something is to be done, interventions, it's that kind of theory is there. So what I understood is probably you want to know why people are required to know what is the clinical implication of letting people know and understanding the lived experience, how it will bring some changes in the research, probably, that you should know that you have sensory processing sensitivity. You're a highly sensitive person. Why?
Right. So to answer that question, SPS or sensory processing sensitivity poses as a risk factor. It's a diathesis basically. And if we already know that the person who is in front of us is a highly sensitive person, we could prevent the development of a lot of mental health conditions which have been implied already
But
in
you know that
previous studies.
this condition is already a comorbid condition with ADHD and autism, CP. There are kids who are highly sensitive. They are sensitive.
Right.
So, is this you want to say that knowing this will prevent any kind of other disorders, because these are neurological disorders, neurodevelopmental disorders.
Right.
Autism है, किसी को CP है,
Hmm.
yeah, they are sensitive. The kids are very highly sensitive. Other than that, what is the need?
Right. So to answer that, in my introduction slide as well, I added this point that it is overlapping, but it is different to the sensory processing difficulties which is seen in neurodevelopmental condition. It's not that people who are highly sensitive, they are autistic or ADHD, right?
Is this a problem?
It's not a problem. That's why it's basically a thing. Just like, I am a woman, but being a woman could also pose as a risk to various things. Or if I am, let's say, from a particular region or a religion, me belonging to that could pose as a risk
Exactly,
factor.
that's what we want to know. Is being a woman is one of the higher thing that it's the complete biological, psychological, and social impact on the society. We are the 50% of the world, so we are, socially implicated, and psychologically, socially, morally, like so many ethics, cultural variations comes too. And obviously we are the persons who are giving birth. A woman is a different entity, complete phenomena.
Yeah.
How it is related, the example that you're giving is different from lived experiences of sensory processing sensitivity. I just want to know, is there any real contribution to the research field? That it is a novel idea, I understand, but is this contributing in any way to the newer research field?
Yes, so while we study and understand the lived experiences of those with sensory processing sensitivity, it is not a disorder, first of all, right? But it can act as a risk factor to develop that. Also, there has been various researches, as I mentioned it here, with respect to individuals who have sensory processing sensitivity, who are highly sensitive people. And it has been linked to alexithymia, let's say. It has been linked to having dip, 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 depression, eating disorder, or maybe anxiety disorder. And they're also more prone to develop PMDD, which is again premenstrual mood dysphoric dysphoria. So it can act as a risk factor to that. And having the knowledge of that can prevent from such conditions to developing. It's the precursor to various mental health conditions. So it's not that uh, it's a noble concept. It has been widely studied, but unfortunately mostly in the West. In India, medical studies for the same are bleak from my review of literature.
Mansi, relax. Okay. See, we are in the paradigm where we are trying to move away from the labeling elements. We are trying to move away from the diagnosis. We are trying to move away from giving those kind of a terms to people. So that is the current movement that we are in. While we are also still struggling with accepting these kind of additional elements like identifying people as neurodivergent, identifying people as LGBTQI, identifying people as queer. So, identifying people as HSP, it is still not something that we can really gulp it in. So, that is something it's okay. So, over a period of time, there may be a state of affair where we have to consider these things in mind. So, don't know whether this will lead to that is something that will grow on or whether it is something that we need to leave it aside. Okay, so while we keep the problem with the construct aside, so I really appreciate your efforts in conceptualizing it, planning up a research, putting in your efforts for the phenomenological analysis of the construct. So problem is not with your research, problem is with the acceptance of this construct. So let's see how this whole thing moves forward. While we are still not okay with having these kind of an identity, uh, okay. So there's another problem is whether we really want to give them that you have this, okay, because once we make them understand, okay, you are an HSP, now my way of looking at things, it is highly influenced by the tag. Okay, so whether I use the tag proactively, constructively, or I use the tag as a defense. So this is something that can be problematic or can be preventive also. So there are a lot of problem with the new construct. So it's okay. So let's see how the research will evolve, how we are going to accept these kind of things over a period of time. Thank you.
Thank you so much.
I would like to thank all the participants for their insightful presentations. I would also like to thank our chairpersons, Dr. Mukund and Dr. Kashyap, for guiding us through the sessions. I would now request the participants to please come and collect the certificates. Ms. Sadaf Amrin Sayal. Big round of applause, please. Ms. Kirtana. Mr. Abudhay Bhargav. Ms. Mansi Rai. I would also like to thank the audience for being such a wonderful and patient audience. Thank you so much, everyone.
beat AD, that was the indexed and adapted test, the transformed scores showed that most of the patients had mild cognitive impairment. As a reference standard, we also administered MOCA on them, which showed that most of the individuals received a score of 24. The CIBA AR scores were used as maintenance criteria to ensure that none of these individuals were in active withdrawal, which could have affected cognitive functioning. We also went into the process of cognitive interviewing the bilingual patients for the purpose of establishing equivalence as well as validity of the translated version. And it demonstrated that most patients found the test extremely engaging and relevant. They understood the stimuli and could relate to them as well. However, a few of the instructions were found complex, and a few of the tests were a little difficult for the individuals to perform. In this context, the iterative approach becomes very important because it provides us the flexibility to create these changes when we move into the next phase of our testing. So the discussion here shows us that the group that we tested and piloted our feasibility study on was fairly homogeneous. The MOCA scores, however, show significant variability, which can be attributed to the fact that MOCA is not a tool that is used for individuals with AUD in the sense it doesn't have norms. It's for patients with MCI, and that can create challenges in the process of assessment. It also sensitizes clinicians to avoid heavy reliance on MOCA scores to track cognitive impairments in individuals and also to proceed with caution when making treatment outcomes. The feasibility of the Kannada version of the BEAT was also very well established, ensuring cultural equivalence as well as relevance. It also consistently helped us identify individuals with impairment within an AUD subset. So in conclusion, what we were able to establish so far is that there is a critical need for standardized and culturally relevant tools for assessing cognitive impairment in AUD patients. The existing tools are not specifically developed for this group and potentially may lead to inaccurate results impacting treatment outcomes. And lastly, developing tools with strong psychometric properties that minimize the influence of language, education, and culture are essential, primarily owing to the diversity in our country. So thank you all for a patient listening.
Minutes is given for the each presentation. 8. So any questions? Sir, any questions from you? Sir, any questions from you?
Basically, this when we adopting any kind of test, there is very many rigor process has to be adopted. So in nutshell, in 4-5 parameters, what are the parameters that we use?
For the process
Yes,
of adaptation.
yeah.
Okay, sir. So as per the ITC guidelines, the first one is a precondition, which basically means taking permission from the original authors and requesting them to share the copyrights with you for this purpose of adaptation. The second one is the actual test development, where you look at the various modifications that need to be done and also involves the translation and back translation. After that, you have the confirmation, which goes into a sample where you try to develop norms and validity for the test. After that, you go into the administration phase where you develop materials and a user manual. And lastly, you go into the guideline phase where you try to identify certain risks and limitations of the adapted version and also sensitize clinicians to the extent where they can generalize these results in different populations when used.
Yeah, that is, but I'm talking about the reliability and validity.
Yes.
What are the psychometric properties when we use that? It start with the item analysis, item total correlation, then reliability analysis, then
sir.
going into for what else?
Okay.
There are 2 to 3 minimal.
Yes, sir.
There are 2 to 3 guidelines that for reliability and validity, criterion validity, predictive validity,
Yes,
kind
sir.
of things. So that part has to be taken very rigorously.
Yes, sir.
And based on that, we have to do.
Yes,
So good work and keep it up. But these are the certain suggestions
Yes,
I
sir.
recommend that you have to
Yes,
follow
sir.
this. Yeah,
So in the modified
Yeah.
version, we've actually done item difficulty, item discrimination, distractor analysis. So we've done these phases. Yes, sir. Due to the paucity of time. So, okay, sir. Okay, sir. I'll keep that in mind.
Important.
Okay, sir.
Because you are modifying or developing or translating one test.
Yes, sir.
So the psychometric property is the backbone of.
Yes, sir. I'll definitely present it in my next time.
So few of my suggestions, you told that there is exhaustive search criteria. You search literature, you need an exhaustive search of literature. Better if you could incorporate what kind of literature search you did, what kind of search engines you used, search strategy you used. May not obviously read everything, just to show to the audience that will be much better. Because using the search of literature, if it is done in an ambiguous way or an objective way, that will be matter a lot. So hope you're presenting for a paper to mention that this is the strategy, search strategy I used. This is the search engines I used. Give it complete sense to them.
Okay.
Otherwise, it becomes very subjective.
Okay, sir.
What will be my exhaustion?
Okay.
Coming that, any sub-components of the scale are there? Sub-constructs are there?
There are, in the original version, there were.
Just quickly tell me that the sub-constructs are
Yes, there are subtests which are there.
Subtest.
Yes, the broad construct is executive function, and then there are subtests which assess the same.
So better in that case, you better, I didn't see any kind of factorial validity. You can see if I approach you could have done. If there are certain sub-constructs, I mean, how could you say that? See, one that is we have emphasized more on the content validation. SCVA approach you have done that.
Yes, sir.
Qualitative criteria.
Yes, sir.
But apart from that content validation, say for example, see, I'll tell any scale, say for positive, happy, scale, whatever scale, all those original items are developed in the Western things.
Correct, sir.
Whether if by assessing these 5 items, whether this is representing the same construct in our Indian population, we do not know.
Yes, sir.
We're taking for that, okay, these 5 sub items might be indicating the things. But unless you do conversion and discriminant validity,
yes, sir.
So that will give a true reflection, even the factorial structure. We are taking for granted since it is a developed scale, you don't have to do it. That's a misnomer.
Okay.
Go to any kind of scale that has been already adopted in actual way, they move beyond content adaptation, but still content adaptation, you have done a good work. This is a suggestion if you can do. If you not do, it's okay because you have already done this starting, but at least about a search criteria, please do.
Yes, sir.
More importance in the public paper.
Yes, sir.
Otherwise, it will be problem.
Yes, sir.
Fine.
I'll definitely explain it. Just to clarify your point, I'm actually in the middle of my PhD, so my work is still continuing. Yes, this is just one phase of my work.
Explore the factor analysis,
yes,
complementary factor analysis.
Yes. So this is all what is planned.
Yes, sir. People mostly neglect that component.
Yes, sir.
Assuming that it is representing the same construct.
Yes, sir.
It doesn't happen in.
We're in the process of
maybe in the 4 sub-constructs original. Maybe in our population, you get only 3.
Correct, sir.
Or you may get more additional 5.
Very true, sir. Very true.
Think on that.
Yes, sir.
Then what is validation? If you are a master student, then we basically need to do that. Okay, thank you.
I'll definitely do that, sir. Thank you so much for all your comments.
Construct validity.
Sorry, sir.
Construct
validity. Yes, sir. Yes. Sir.
that part in duplication.
Yes, sir.
Come under the validation part.
Yes, sir. Thank you so much for your comments. Thank you, everyone. Thank you so much, sir, for your insights. Thank you, Ms. Anaga. I'd like to invite Ms. Hansika.
You are noting the time, right? You're not seeing the time.
A very good afternoon to the chairpersons and everyone present in the audience. I am Hansika, and here today I will be presenting a clinical case study, Torn Between Attachment and Abandonment, a case of emotional dysregulation and interpersonal instability in borderline personality disorder. So the objectives of the presentation are to describe the clinical presentation or give a clinical picture of a patient with emotionally unstable personality disorder, to explore psychosocial and developmental factors linked to maladaptive coping and self-harming behavior, to understand how conflicting needs for attachment and fear of abandonment shape emotional dysregulation in EUPD. To start with the case summary, the index patient, a 32-year-old female running her own fashion designing business, hailing from a high socioeconomic background, was brought by her family members with the chief complaints of increased anger, irritability, with a tendency to harm self and act without thinking things through since 2016. Feelings of sadness, frequent crying spells, loneliness, sleep disturbances, and low energy since November 2023, with insidious onset, continuous course, and deteriorating progress. Biological functions suggestive of decreased appetite and difficulties in falling and maintaining sleep. The history further suggests a not so well adjusted premorbid personality. MSc revealed depressed affect, thought content characterized by worry about future, ideas of helplessness, and overvalued ideas with partially impaired personal and intact social judgment with grade 3 insight. Now, a reflection on the family dynamics and the childhood of the patient. The patient described an uncordial relationship with her mother, marked by frequent conflicts, criticism, and punitive punishments. Relationship with her father was distant and emotionally detached. He was often absent and unaware of the abuse. Family environment was stressful and is still stressful and conflictual, characterized by indirect communication, critical comments, and lack of collaborative decision making. Childhood history: extroverted, outspoken, and a sensitive child with temper tantrums, stubbornness, and difficulty maintaining friendships. Relationship history and self-harm history. To start with relationship history, in 2016, the patient met Mr. J and entered a romantic relationship with him. In 2018, she broke up with him because of caste issues. She wanted to get married, but he said, because of caste issues, we cannot get married. But soon after, they reconciled again. In 2019, she had a roka with Mr. S, who she met through an arranged setup. And after the roka was called off because of reasons cited by Mr. S, she reconnected with Mr. J. In 2020, relationship with Mr. J ended. Brief 3-month relationship with Mr. Z. In 2021, she had a roka with Mr. P, who again she met through an arranged setup and ended due to financial demands from Mr. P's side. In 2023, she again reconnected with Mr. J and traveled to London to spend time with him for a month. In October 2024, she finally had her roka with Mr. J, but soon after the roka, 1 week after the roka, Mr. J stopped all contact with her. Coming to the self-harm history, in 2016, she slit her wrist after an argument with her mother. In 2020, she ingested 10 paracetamol tablets post her breakup. In 2024, she ingested washing powder and clonotril 0.5 mg after her roka ended. Reports self-harm during emotional distress and describes relief after acts. Denies current suicidal intent but has passive death wishes during crisis. Now coming to the case conceptualization. Coming to the genetic predisposition, her paternal aunt had depression, which made her more vulnerable. Coming to the high-risk transactions. So this has been adapted from Linhen's extended model. Negative, when we come, there are two aspects, child contribution and caregiver contribution. When we come to child contribution, we have negative affectivity, impulsivity, and high emotional sensitivity. And when we come to caregiver contribution, we have invalidation of emotions, inadequate coaching of emotions, negative reinforcement of emotional expression, ineffective parenting due to family stressors, because of which there is inherited impulse control deficits, which are met with the environmental reinforcement of emotional lability. This leads to increased risk for psychopathology and also heightened emotional dysregulation, which includes high emotional sensitivity, intense response to emotional stimuli, and slow return to baseline. This in turn leads to distorted thinking, cannot control mood-dependent behavior, and cannot organize to achieve non-mood-dependent goals, which leads to increased risk for negative outcomes in 4 areas: social, cognitive, emotional, and behavioral. When we talk about social, there is unstable relationship, fear of abandonment, and interpersonal conflicts. When we talk about cognitive, low self-efficacy and self-doubt, helplessness. And when we talk about emotional, chronic sadness and emotional instability and anger. And when we talk about behavioral, impulsive spending and reckless decisions, self-harm as emotional regulation and emotional outbursts. Coming to the discussion, the patient's life history reflects a core conflict between the need for closeness and fear of abandonment, leading to unstable and intense relationships consistent with empirical findings on insecure attachment patterns in BPD. Early inconsistent caregiving and emotional invalidation likely fostered insecure attachment, shaping dependency and mistrust, which aligns with studies linking early attachment disruptions to emotional dysregulation and interpersonal instability. Emotional dysregulation and impulsive acts of self-harm and overspending function as maladaptive strategies to maintain attachment or avoid rejection, reflecting how individuals with BPD manage perceived threats of abandonment. Her interpersonal instability mirrors the push and pull dynamic typical of BPD, oscillating between idealization and devaluation, further emphasizing the internal struggle between attachment needs and autonomy. These are the references. Thank you. Are there any questions?
So this borderline personality disorder, so what kind of assessment you have carried out? Any assessment?
I have carried out TAT, I have carried out Rorschach and Hamby.
So that profile is reflected in that. In nutshell, you can just brief about the
Criteria was meeting for emotionally unstable personality disorder.
Ah.
In TAT, there were needs of affiliation, of succurrence, of achievement. There was a conflict between the need of affiliation and need of achievement. When we come to environment, the environment was defined as uncongenial but supportive at the time. And there were anxiety related to fear of helplessness and fear of being left alone.
What about
In Hamby, it was mild depressive. There were mild depressive symptoms. In Rorschach, when we come to interpersonal and emotional areas, so in emotional areas, it was there that she makes emotional decisions. Her emotions overpower her logical side, and often she makes impulsive decisions. When it comes to stress, if the environment is structured, if there is a certainty, she is better able to function in a structured environment. But if there is a chaos or if there is some challenge, then she takes either emotional decision or an impulsive decision.
Yeah. So thank you. There are a few suggestions. I won't waste time of asking questions. See, this is, it's a paper presentation. I mean, the kind of presentation you did, it seems to be more anecdotal than empirical. So what exactly, if it is a case study, there is a steps of how to do a presentation of a case study. Say, for example, you need to tell what are the themes that you are looking into it. What are the things you are investigating? What are the aims and objectives of it? On basis of that, what you found. The idea of the case study is to generate an hypothesis. For cross-sectional other studies, there we are testing the hypothesis or proving the hypothesis later on. But it's a generating of a new hypothesis that can be tested in other part of the design. So what objectives are there? Otherwise, it's simply like case you took and you discussed it. It may be, yes, it's your effort is good, but when you're coming as a paper presentation, it should be having a more empirical structured paradigm on the basis which we are trying to give certain input so that you can generate certain themes. Say for one assessment you have done, what are your expectations from that assessment? The assessment you have done only, have you done?
Yes.
That is what thing. At least in case studies, then in the paper presentation, you need to have at least 3 people verifying the assessment. And the 3 people need to, that is the concept of triangulation, you need to bring it that, how that is being verified. Otherwise, it simply is an anecdotal way of making a case. But thinking about case study as in a paper, this element should be there so that it considers an empirical work than an anecdotal work.
So this was my first.
It's okay. I'm just suggestion. I'm just a suggestion.
But I understood what you're trying to say.
Otherwise, it's simply like, I took a case, I presented it.
And everything, I realized how I could have.
And haven't framed another decided theme. This is the theme that I'm trying to make it, write the transcript, write the coding framework of that. If it is a case study can be presented, no doubt in that. But with an empirical way. It's in an anecdote. Okay? Take it in a suggestion. Okay? Thank you.
Any questions from audience?
Thank you so much, sir. Thank you, Hansika. I'd like to invite Ms. Shrija for a presentation.
Use this one. This one. Okay. No, I need question. No, things.
Good afternoon to everyone present here. My name is Shrija Mukherjee, and I'm pursuing MPhil in clinical psychology from Amity University, Noida. And today I'll be presenting a paper titled Adolescent Self-Harm and Emotional Instability, a case of emerging emotionally unstable personality disorder. So this will be the overview of my presentation. Okay. So the objective of my presentation is to examine the interpersonal mechanism underlying self-harm and mood instability in adolescent. And I've conceptualized the case through non-suicidal self-injury, that is NSSI framework, and how emphasizing how it functions as a maladaptive coping mechanism for emotion regulation in an environment which is perceived as invalidating by the patient. And it also, and another objective is to demonstrate how NSSI functions as a maintaining factor for affective instability and impulsivity, which can pose as a risk factor for the emergence of emotionally unstable personality disorder, thus requiring early detection and intervention. So coming to the case summary, Miss KP is a 15 years old female, class 11 commerce student coming from a Christian nuclear family belonging to upper middle socioeconomic status, who came to the current setup accompanied by her mother. The chief complaints were feeling low, irritability, emotional instability marked by anger outbursts and crying spells, difficulties in interpersonal relationships such as with her family and friends, suicidal ideation and deliberate self-harm behavior, along with reduced energy and reduced appetite. So this is a brief case summary. So her symptoms started around 1.5 years ago in early 2024, with marked by onset of persistent sadness after increased parental attention towards her brother's education and academic performance, which led to increased fights between the patient and the mother. She also perceived a lack of support from her father and her brother. So this situation of tension within the household led her to start engaging in cutting behavior, usually which occurred after fights at her home. In December 2024, she planned a suicide attempt. However, on the day when she planned it, she went out with her friends and experienced better mood, as a result of which she did not go through with the plan. Coming to 2025 in January, she entered a relationship which ended after discovering her partner's continued attachment to an ex-figure. In February to May, she reported fatigue, poor appetite, loss of academic interest, and discontinued going to gym and even performed poorly on her examinations. In May to June, her family shifted to Delhi, where again she continued experiencing low mood, especially after comparison with her brother's scores. Coming to July 2025, her frequency of self-harm increased to multiple times per week, along with increased suicidal ideation. She also experienced another breakup of her second romantic relationship. And in September 2025, she again expressed suicidal plan to be, she wanted to engage in that act after Diwali. However, she reported reduction in self-harm due to her increased engagement in academics. Right. So this is the family structure. The patient has grown up in a nuclear family with her mother, father, and her brother. Okay. Now, coming to temperament, it was found to be a difficult temperament with high activity level, moderate level of adaptability, moderate level of rhythmicity, moderate level of approach withdrawal, low level of threshold, high intensity of reaction, moderate mood, high level of distractibility, and low persistence. Okay. Now coming to the case conceptualization. So I've conceptualized the case using the cognitive emotional model of NSSI given by Hasking in 2016. So the model explains how the initial or occasional use of NSSI, how it uh, gradually converts into a persistent maintaining behavior in the case of the current patient. So first, there is representation of NSSI, which indicates how the patient views this act of self-harm. She uses it as a means of coping and also uses it as a means to punish herself, giving her, she views her scars as deserving of her pain. Now, which is usually occurring after a triggering situation, which is marked by high level of emotional sensitivity. Whenever her mother passes a comment, there's a high, intense emotional reaction which lasts for a long duration, marked by prolonged anger and guilt. Now, there is also a representation of self, how she views herself, such as ideas that I'm not good enough as a daughter, as a partner. And along with this, there is NSSI related cognitions, such as viewing that self-harm is the only way to feel better and no other way is there. And also self-efficacy expectancies, which basically means that she doubts her ability to feel better using other alternative strategies. Right. Now, when a triggering situation occurs, there is low level of cognitive reappraisal and high rumination, which leads to low levels of distress tolerance, low alternative emotion regulation strategies, high level of expressive suppression. She's unable to express her emotions or communicate them. And there is low level of emotional awareness. All these is followed by using NSSI to modulate her response. It helps her regulate her emotions. It also helps us to avoid the emotion. She's unable to process the emotion and immediately engages in the act to feel relieved. And also, she uses NSSI to avoid the situation itself. Right. Right. So these are some of the assessments I conducted. So the findings reveal moderate depressive symptoms, severe suicidal ideation, explosive personality pattern, and also needs for autonomy, abasement, and rejection, with conflicts between need for affiliation and need for rejection, as well as need for autonomy versus need for abasement. And anxieties of desertion and disapproval were also observed, and defenses commonly used were projection and rationalization. Now coming to interventions. So the first couple of sessions involved detailed history taking, but more importantly, it involved developing rapport so that the patient views the therapeutic space as a safe and non-judgmental environment to open up and share her feelings. And also because of the nature of symptoms, safety planning was initiated. Session 3 and 4 was focused on psychoeducation and safety measures, especially with the mother informant, to remove sharp objects nearby and increase supervision in a cautious manner, but rather than an intrusive manner. In session 5 to 6 with the patient, introduced emotion labeling and tracking. So the patient, when she was asked, why do you engage in self-harm, she reported, I don't know. So which revealed there's a lack of insight and lack of emotional awareness as to why she actually engages in the act, which is why this activity was introduced, along with distress tolerance and suggesting safe alternatives to self-harm. And with the mother, communication strategies were also taught with the mother so that in conflict situations, she's able to actively listen to the patient without blaming or criticizing. And future plan involves mindfulness for emotional awareness, developing distress tolerance and interpersonal skills, family-based communication training involving the brother and the father, and also cognitive restructuring targeting her self-critical beliefs and relapse prevention. Lastly, so lastly, the implication. This case illustrates how NSSI emergence from heightened emotional reactivity and lack of cognitive control, and how it is maintained through negative reinforcement, and persistent reliance on self-injury can reinforce this emotional dysregulation and impulsivity into enduring personality patterns over time. So these are my references, and thank you, everyone.
Yeah. Any questions from your side? No. Again, I have few suggestions. As I commented on the last paper, you need to have that empirical approach towards, and otherwise simply seems like a case study. I mean, case you took and you discussed.
Right.
It's like a case discussion then and then paper presentation. Anyways, that you can develop. So better what I suggest is that there is something known as care guidelines for the case studies, care guidelines, and that is available in the Equator Network. Simply type Equator Network. Within that, for every kind of study, there is a guideline. How the case study has to be reported. It's written care guidelines by, I don't know who's by, but Equator Network is the website that's for everyone. That is the most cited literature for any kind of guidelines. Find care. You will get a sense of it, what exactly lacking.
Yes.
Then we can present even case study in that appropriate, then it will seem as an empirical. Okay.
Okay. Thank you, sir, for the suggestion.
Thank you. Thank you. That's only 3 papers are there. Only 3 papers are there.
No, there's one more, last one. Yes.
Just a minute. When it went to the I think that's what I think the paper 5 absent. Yes. That's paper 3 right. That's nice one.
Thank you, Shrija. I'd like to invite Ms. Jinsa.
Okay. Good morning, everyone. My name is Jinsa Jacob. I'm doing my MPhil clinical psychology trainee from Amity University. So my paper presentation titled Beyond Symptoms, Integrating Clinical, Cultural and Clinical Insight in the Assessment of Recurrent Depressive Disorder with Psychotic Features, under the guidance of Dr. Devika Srivastav and co-guidance of Dr. Sneha Das. Now moving on to the introduction part. So as my title clearly says, that it's a case of RDD with psychotic features. So what is RDD? RDD is basically recurrent depressive disorder, which is marked by repetitive episodes of depressive disorders, which is separated by partial or full remissions. But yes, there should not be a history of manic or hypomanic episodes. When I talk about prevalence, so globally, it's actually a global burden of disease when it comes to affective disorders, specifically like depression, wherein it calculates around like 4.4% of the populations are suffering from this. When I talk about specifically about India, the prevalence is of around 5.25%, with the point prevalence is of 2.6%. Now, from this, the title also of the CPC icon is that integrating that how cultural competence is really much important when it comes to diagnosing and the assessment and for the management also. So similarly, I took up this case because it clearly highlights that how cultural insight is important when it comes to conceptualizing a case and also for the treatment management. So that because every culture, the expression of symptom manifestation varies in every culture. For example, like because based on the somatic complaints, moral guilt, or I failed as a responsibility, familial responsibility or relational responsibility. So based on that. Now moving on to the aim of the study. It is to elucidate how sociocultural frameworks and contextual factors shape the symptom manifestation, illness trajectory, and clinical understanding of recurrent depressive disorders with psychotic features. Now moving on to the method portion. So yeah, its a design is a single case study adopting a more descriptive and exploratory design, where the procedure is basically the clinical data has been taken from the semi-structured interviews, the information from the patients, as well as it was been corroborated with the informants as well. There was medical records and past psychiatric histories, the reports has also been viewed. There was mental status examination at cross-sectional levels have been taken. There was administration of standardized psychological and neurocognitive assessments were also done. And also the case has been also viewed and analyzed by a cultural formulation interview in order to capture the cultural distress or the distress that is being explained through cultural dimensions as well. And now moving on to the case summary. So it's basically a case that coming to the social demographics. It's Mrs. X, a 56-year-old married Hindu woman residing in Delhi, belonging to a lower middle socioeconomic status background with no formal education. She had presented with the chief complaints of persistent sadness, hopelessness, ideas of guilt, self-blame, diminished energy, somatic complaints, increased irritability, with disturbed ADLs, and there is mood congruent auditory hallucinations as well. So when it comes to timeline, there are the current episode is of the 4th episode. Before that, there are 3 episodes that happened. Number 1 was the main factor was because of the lockdown period. The husband lost his job. Because of that, she was diagnosed with moderate depressive episode and she was started on medication for around 6 to 7 months. The second episode was when her mother passed away and she couldn't attend her funeral because of the lockdown period. And this actually resulted in a more unresolved grief that I couldn't see my mother at her last stage. And because of that, it actually made her felt that her own verbatim that she said, "मैं एक अच्छी बेटी नहीं हूँ." So that also kept in her mind deep rooted and that affected her all other relationships as well, that I'm not a good mother, that I'm not a good daughter. The third factor, there is no actually stressor that has been identified for the 3rd episode, but still there was mild depressive episode. And considering also one more information that I have to talk about is for the 2nd episodes, there was treatment resistant depression as well, because she was not acting on the medication. She was not responding to the medication. So the ECT was administered for around like 8 sessions, but because catatonic depression was also observed in the 2nd episode. For the 3rd episode, just because of the past episodes, the family was pretty cautious about the 3rd episode. So they took her for the mild depressive episode and they started on medications. And the 4th one, and for all of these 4th episodes, none of them she had got for psychotherapy treatment. All was for the medications. Now moving on to the MSc findings, again, reduced psychomotor activity, there's low volume, low tone, there's delays reaction time, depressed mood with restrictive affect, there is preoccupations about the stresses, there is feeling of hopelessness, worthlessness, and death wishes. And also a perception for there's mood congruent auditory hallucinations. The medical history suggests that she had hypothyroidism and hypertension. The family history suggests that there is psychiatric family history, there's depression in mother as well as elder brother, and also alcohol dependence in the elder brother. The family dynamic is mostly cohesive and cordial, but because of the 4th episode, the family is little strained, having relationship with each other, emotional withdrawal as well as social withdrawal. Pre-morbid personality suggests that she have a cluster C personality traits. She's very self-critical when it comes to stresses or something. She avoids completely emotionally as well as withdraws herself from everything. Now moving on to the assessments. Hammy-Hamdy, all the objective assessments reveal that there is moderate to severe symptoms. Panasis revealed that there is mood congruent psychotic features. When it comes to projective test, this, for example, TAT, it was revealed that how her super ego specifically has rigid, guilt-laden ideas, like having strict right and wrong approaches. If that is taken away from that spectrum of right and wrong, then it's high likelihood she have guilt ideas, self-blame, being self-critical about herself. The Rorschach findings highly reveal that because of there are low productivity and high morbid responses, it clearly says that there is perceptual distortions, cognitive rigidity, and depressive ruminations. Also, PGI-BBD was also done because of she having cognitive complaints as well. So the dimensional score, which also revealed that there is impairment because the cognitive inefficiency. Now it also depends on, it can be because secondary to the affective processes because of that. So this is the case conceptualization. So I've conceptualized this through a temporal contextual model, but it says that yes, through a disorder, it affects our affect, cognition, and behavior. But what are the rest of the things that gets affected? So it's the core diathesis, which is like there is biological vulnerability as well as there is medical comorbidity also. And there are stable interactions with that, with the stable personality traits like cluster C traits. And because of that, there is temporal accumulation of the stressors that has been going since 2020 to 2024. And her interaction with herself, with her ideas, with her own weird things, and also her interactions with the world. She withdraws herself from her. She blames everything for herself and being critical of it. That all mix-ups and give her the increased vulnerability to have relapses in her depressive episodes. So again, discussion also reveals that through this case studies have been pretty much clear that this increased vulnerability of the relapse source has mostly the ideas or the deep-rooted ideas that she has on herself, because that is culturally reinforced. And also the culture schemas of duty, sacrifice, maternal responsibility that has played a major role in symptom expression as well as the manifestation. So it becomes really important to focus on relapse prevention and the early warning signs. So I just want to say this, that focusing on this approach from a very multimodal context sensitive interventions like culturally adapted way becomes more helpful when it comes to addressing this case as well as for the management of the case. Thank you.
Any questions from your side? Yeah, this is having.
You mentioned that the diagnosis is recurrent depression with psychotic features, which means that she was having active psychotic features. Could you justify the assessments that you did in the context of those features and whether there were any contraindications, especially for cognitive assessments?
Okay, so basically the rationale behind using cognitive assessment was because of the repetitive cognitive declines that has been reported by the patients. For example, कुछ याद नहीं रहा था, या ये सारी काफी चीजें, and also because of the past repetitive episodes of the depressive episodes, and also ECT was also being done. There are high chances that there can be cognitive disturbances also. Also, this is not like the patient came and then the assessments were done. Once the symptoms were stabilized, psychotic symptoms reduced, then these assessments was happened. Otherwise, Rorschach couldn't be able to done because responses, because the state when she came in was severe depressive episode. So in that stage, she was not even able to speak or give long answers for that. So these assessments were done after when she had like properly stabled with the medications.
Thank you for your response. Good presentation.
Sir, any question? Okay. See, again, the same applies to what other applies. Your design should be case study, not something exploratory, doesn't make any sense. It's a case study, simple. Same applies, follow the care guidelines. Since it's the case study, another two things I did not speak it to other candidates, same applies to you. In a quantitative assessment, we do a quality check. So in a qualitative study, there are two significant quality check. One is triangulation, how we are coming to a conclusion using a multiple methods. Another use is now more is reflexivity. Reflexivity, and whether what is my bias and judgment, how that is I'm checking to that, how steps I have taken to minimize that. So these two things, a report on triangulation, a report on reflexivity is considered to be now not mandatory, I'll say, but very necessary. Implement that in your things, it will give a more empirical approach. You're a MPhil scholar or a PhD scholar? MPhil, but okay, say maybe for the learning for the next things, why even in the another presentations, whenever you do, try to include these three things. Now the beauty about is that every guidelines has been developed. You don't have to think so much on that. Follow those things. It will be much better. Okay, thank you.
Thank you.
No, you can find them both are you can put it here and I'll just find the count of something. Since I want the correction, was very something. How will be different? Final. So you write down the first. Yeah.
Yes. That brings us to the end of this paper discussion. On behalf of everyone present, I extend my heartfelt thank you to our chairpersons, Dr. Nagle and Dr. Narendranath, for guiding the sessions, to all the presenters, and for your thoughtful and inspiring presentations. Thank you to our audience for your time and engagement. You can collect your certificates from the reception. If you're present, we have it here. You can take it and go. Okay. Thank you so much. इसको कैसे भेजूं सर?
In fact, you are Muslim of Agri, right? From Agri, you want that. You are from my year, or yeah.
किसमें मेल करो? पेन ड्राइव दूं क्या मैं? मेल कर सकते हैं ना, मैंने तो जब मेल ही किया था ऑडी एट ऑडी मेल कर चुकी है ना, हाँ तो रहेगा ना मेल बॉक्स में. बस अभी अगर हम प्रोजेक्ट करें एक फोटो निकालो दरवाजे तस्वीरें में हाँ you have schema नहीं schema you can after the just finish. Okay, this is
So, ma'am, yeah.
part of it.
Yes, yeah.
Then it is चले आज. This background needs to be there. This it's coming, no? It was. Yeah. खाली एक इसके साथ निकाल. Without नहीं. Yeah. And then
अभी जो उन्होंने evaluate किया ये हमसे नहीं हो गया
कनेक्टेड है ये?
Good afternoon, everybody. A very warm welcome to all present here. We are delighted to have you with us for the symposium titled Chair Work on Schema Therapy, an effective technique to work with the coping mechanism. This session aims to explore the use of chair work in schema therapy as a powerful experiential technique to address and transform maladaptive coping modes. It focuses on how this method facilitates deeper emotional processing, enhancing self awareness, and promotes integration between different parts of the self. Drawing from both clinical practice and research, the session highlights its effectiveness in helping clients move beyond rigid coping patterns towards healthier emotional functioning. I would be introducing the chairperson. It is my absolute honor to introduce the esteemed chairperson for the session, Dr. Maithili Hazarika ma'am. She is an associate professor of clinical psychology at Guwahati Medical College and Hospital in Assam. Her work focuses on child and adolescent mental health, substance use and neurocognition, as well as geriatric mental health. She has been recognized by the WHO as the lead of the COVID-19 Mental Health Task Force and has received an award for the Uppsala Health Summit, European Union, for her contribution to global mental health. Now, I would like to introduce my speakers. We are privileged to have with us distinguished panel of speakers who will share their insights on this important theme. Our first speaker of the day is Dr. Priya Puri ma'am, clinical psychologist and entrepreneur specializing in trauma-informed care and schema therapy. She holds an MPhil in clinical psychology from the West Bengal University of Health Sciences, Calcutta, and a PhD in clinical psychology from NIMHANS, Bengaluru. As a founder and chief clinical psychologist at the Healing Space, she integrates evidence based approaches with holistic healing practices to support individuals in their journey towards recovery and emotional well being. A certified trauma specialist, Dr. Puri's work emphasizes compassion, empowerment, and transformation in the therapeutic processes. Our next speaker, Ms. Prerna Srivastava ma'am, is a licensed clinical psychologist and private practitioner at the Healing Space. She holds an MPhil in clinical psychology from Institute of Psychiatry, Calcutta, and is currently pursuing her PhD in psychology from Guwahati University. Her major areas of interest include schema therapy, attachment-informed psychotherapy, and the treatment of anxiety, obsessive-compulsive disorders, and related disorders. Ms. Prerna works through a trauma and attachment-informed lens and is formally trained in schema therapy and body-focused approaches, integrating these frameworks to facilitate deep emotional healing and growth. I would like to welcome all them on stage with a round of applause. I would kindly request everyone to move a little forward. You can take the first row as well. That would not be a problem for us. This front row, please, as well. The right side and the left side, both.
Very good afternoon to all of you present here. I'm so happy to chair this session because it is a very, a new approach. I believe people are getting trained in schema therapy and they are doing very nice work in this area, what I have understood by interacting with both of them. And I think, as she has already mentioned, it is a variant of cognitive behavior therapy, going through the psychodynamic processes, rooted in, again, childhood experiences. Then we definitely think about Bowlby's attachment and so many other child psychotherapists and the theories based on them. So maybe how to integrate. No, we always do all this eclectic model. We always talk about eclectic therapy. So maybe the schema therapy is a new name given to the eclectic approaches of psychotherapy, what I have understood so far. And it's basically founded with the principle of, with treatment-resistant psychological disorders. So now new research is also going on. What we will come to know from them. I don't know what they are going to present, but it is about cancer, chronic medical diseases, even tinnitus. In tinnitus also schema therapy is used. So it's good because of the fact that I come from the general medical setting, right? I'm in Guwahati Medical College, and I have 3 years back, I have founded the Department of Clinical Psychology in Guwahati Medical College. But to tell you the truth, what happened is that I started, 25 years back, my journey, and 3 years back, the department was separated, and I wanted to create a new niche because there is no Department of Clinical Psychology anywhere in India in a government setting. And then we had conferences, and I did what? All the interns were sent to different departments like gynecology, pediatrics, neurology, a lot of other departments I had sent them. And I have found the impact that they did, the interns in those departments. You can't believe the medical fraternity of other domains wanted clinical psychologist services. Even in the baby room, I mean to say in the delivery room. No, I sent all my interns to the delivery room, and the first day they were shocked and they did not want to go. And where are you sending, ma'am, and all. Later on, after the experience, I remember one boy coming out, an intern, he is a male. He says that my whole image towards pregnancy and childbirth has changed. Immense respect to women from today, because he saw the delivery in front of him, the pain that the women had undergone. So I think the schema that was in him maybe has changed, with one or two experiences in the labor room. So I think this is something we need to know more in detail. And I would like Priya to start with the introduction. Thank you for your participation.
Hello and good afternoon, everybody. So I'm so happy to see the numbers. And so today we will be doing this symposium on chair work in schema therapy, and hopefully, if time permits, I would also love to do a brief demonstration, because an experiential technique cannot be learned only by means of theoretically understanding it. It's all about seeing what we are doing, how it is happening, right? It is all about seeing that magic unfold right in front of your eyes. So I am just going to introduce the learning goals, and then I'll invite Prerna to help us with the first learning goal. So I've sort of divided our presentation into the following parts. First, we will try to understand the different coping mechanisms, or as in the language of schema therapy, we call them coping modes. I understand that many of you might not be very familiar with schema therapy, or maybe I probably are not, most of you might not be trained in it. So I've tried to keep it a little bit in this way, that even a clinical psychologist who is not formally trained in schema therapy but is a clinician will be able to understand what we are talking about. We'll try to keep the technical terms of schema therapy a little limited, or even if we are using the technical terms, we'll try to explain those terms. Because in schema therapy, there's a lot of technical terms, a lot of taxonomy that is there. So we'll first try to understand about the different coping modes or coping mechanisms, and then we will understand how these coping mechanisms are actually maintaining the schemas. Okay. Following that, we will try to understand about chair work, how it is used to deal with the coping mechanisms. And finally, if time permits, we will try to do a demonstration. So I would like to invite Prerna to address the first learning goal of understanding about different coping modes.
Thank you, Dr. Priya, and good afternoon, everyone. So let us start with the first goal of today's presentation, which is understanding schema therapy, a brief overview. Some of you might have attended yesterday's presentation from Dr. Manjula and Dr. Priya, and they had a very elaborate discussion on schema therapy. But today we'll just touch upon it. So starting with what is schema therapy? Jeffrey Young developed this integrative framework wherein he blended elements from CBT, attachment theory, psychodynamic understanding, and experiential work into one coherent model of treatment. Now, all of us, we have core emotional needs, that of love, safety, acceptance, freedom to explore, play, autonomy. When these needs are not met in childhood, that is when we develop certain emotional cognitive patterns, which we know as early maladaptive schemas. Now, these are those deep rooted feelings and beliefs that, I am not good enough, I am not loved enough, or I'm unlovable, I can't rely on anyone. These are the stories that then becomes, our story of life as we grow up. So the goal of schema therapy is to help in identifying, understanding, and healing these maladaptive schemas. Now, at the very heart of schema therapy lies the attachment foundation. So the attachment foundations helps us have an understanding of human development. The early caregiver bonds form an emotional blueprint of how we view ourselves and our surroundings and other people during our adulthood. If the caregiving is responsive and consistent, the child internalizes a sense of worth and safety, wherein if the caregiving is inconsistent, unresponsive, neglectful, that is where the maladaptive schema starts developing, such as that of defectiveness, abandonment, mistrust, etc. These schemas then becomes the lens through which we see the world, ourselves, and people around. Now, how do these schemas bring out coping modes? When our schema is activated or triggered, say we are feeling rejected, we are feeling criticized or neglected, it brings out a lot of emotional pain and overwhelm. And then we automatically bring out our protective mechanisms, which in schema therapy we know as coping modes. So, coping modes are those behavioral and emotional responses that individuals adopt in reaction to schema activation. They help us in managing distress and gain back the strength, the control, and equilibrium. Now, it's okay, short term may, but the problem is that it leads to a long term cost of reinforcing the very same schemas which were activated in the first place. How this is done will be dealt in detail by Dr. Priya Puri in the next half of the presentation. But just to brief you about it, it starts with schema activation, which then leads to emotional pain, which then brings out the coping responses, which is beneficial in the temporary present moment, short-term relief, but eventually leading to long-term reinforcement of same schemas. Now, talking about coping modes, we have broadly 3 categories of coping modes given by Jeffrey Young. First one is surrender modes. Second one is avoidant or detached mode, and third is overcompensator modes. Now, these are broad categories, like umbrella categories, and we have several subcategories underneath. But today we'll just focus on the broader categories. So to start with, the first category is surrender modes. Now here, submission becomes a strategy for safety and survival. Now, what the individual, Young actually use surrender mode to describe two major functions. One is surrendering to the schemas, what the stories that the schema is telling us, like, yes, I am unlovable, I am incapable, what can I do? So they're just surrendering it to the schemas and the stories that their schemas are telling them. Second type of surrender is where they surrender to others because my needs are not that important. It's not valid enough. I need to cater to other people's need. These individuals, they appear very accommodating, very easygoing, accepting of things. But underneath, there is a layer of fear of rejection and disapproval. The emotional logic that goes in this mode is, if I stay small or pleasing, I won't be abandoned or hurt. And hence, it protects them by helping them maintain the attachment and avoiding punishment, but it also suppresses their autonomy. Now, the tragedy is that by doing this, by suppressing their anger, by invalidating and not asserting their own needs, um, in the hope that it helps with the survival, it actually feeds into the same stories that these schemas are telling the individual. Like, you are not worthy of love until you stay small, or you need to cater to others to get that approval. And hence the cycle keeps getting reinforced. Now, we'll move, and the behavioral expressions that this type of mode shows can vary from being very passive, compliant, to remaining in unfulfilling or abusive relationships. Say, somebody with abandonment schema would come up with the thoughts like, but it's better to be with somebody than, just be alone, because their schema tells them that you will be abandoned anyway. So hence they are just complying, surrendering to the abusive partner. The second type is avoidant or detached. Now here, disconnection becomes the defense. The core pattern is where the individual just blocks out or shuts down all the emotions altogether. The emotional logic being, if I don't feel, I can't be hurt. Now, again, this provides short-term relief, but it obstructs, it hinders the healing process. I'm sure a lot of you might be seeing clients where you will face resistance and you don't know why. So, according to schema therapy, if you go by their modes, and this is one thing which comes up very commonly, is their detachment. They'll just detach, and it will look like, oh, they are they're doing it in a very healthy manner because they appear very calm, composed, very rational. But again, is it the calmness, or is it actually rational, or is it that underlying disconnection or detachment which is presenting like that? So there are various forms of avoidance, ranging from emotional avoidance, wherein just going numb, forgetting about the topic that they had to discuss, to behavioral avoidance, not talking about the topic purposefully, or not visiting those places, not meeting those people who trigger them. So behaviorally avoiding. And last one is cognitive avoidance, which is where a lot of intellectualization. I mean, I'm sure you'll meet so many clients who would come out with as being very self-aware. They'll give you a lot of logic about everything. They know everything, why this is happening to me and where this developed from. But again, what is happening because of that? The emotions, that is where they are disconnected. So a lot of intellectualization, a lot of overthinking is how cognitive disconnection or cognitive avoidance presents with. And now it's like building walls. The wall protects them from pain, but it also prevents the healing process. And hence, it's like, the same protective layer that they built for themselves to prevent pain is now becoming a prison of their own isolation. The last category is overcompensator, which is where the person rebels. So the first mode that we talked about was that the person simply believes the schema. But here, they just rebel against it. So it's like the schema tells them that you are not, you will fail. And they will feel like, okay, then let me try relentlessly to succeed. The schema tells that you are unlovable. I will be perfect. I'll be so perfect that people will love me. People will approve of me. So it's like an armor which looks like a lot of confidence, a lot of assertiveness, sometimes even arrogance. But it's not actually arrogance. It's like that, a stage show that they're putting up to hide the vulnerability underneath. The vulnerability of feeling unsafe, feeling unprotected, and feeling like I will be rejected again. So the emotional logic goes, if I am perfect or in control, no one can hurt me. This is where the deep insecurity or shame is being addressed. Now, in therapy, they might present in various forms. Um, Sometimes also in very attacking forms, sometimes testing your limits, sometimes aggrandizing themselves, sometimes being overly controlling of your sessions. And this is where you recognize these modes coming up in your clients. So all these three modes that we discussed about, they might look very different, but they are all serving one single purpose, which is ensuring safety and survival. What we need to also keep in mind is they're not bad, they're not wrong. They were very much needed at one point of the individual's life during the childhood when the resources were limited. It is only after a certain time where it has outlived its purpose into adulthood is where we start categorizing them as maladaptive coping modes or coping styles. So I think that is all about the coping styles and coping modes. I'll now invite Dr. Priya to help us understand how this leads to the reinforcement of schema and how chair work is done along it. Thank you.
Thank you so much, Prerna, for setting the background right. So, three different categories, broader categories of coping mechanisms is what we understood, right? That a person can surrender, or a person might avoid, or the person might overcompensate. And we can sort of look at it also from the survival mechanisms, fight, flight, freeze. So we can think of the surrendering as freeze, कि कुछ नहीं हो सकता, अब क्या कर सकते हैं, now this is how it is going to be, right? We can think of overcompensator as fight, that I have to fight this cannot be my narrative, this is not true, right? So they are trying to go against it. And it is also known as inversion mechanism in schema therapy, where they are trying to invert it. Okay. And we can look at avoidant mechanisms, avoidant coping styles as flight, that let me run away from this. If I don't see this, then maybe this doesn't exist. Okay, now we'll try to briefly understand something known as schema perpetuation through coping. So Prerna mentioned that the schemas actually are maintained. But what is the coping mechanism trying to do? The coping mechanism is trying to avoid the pain that the schema is giving, right? For example, if I have an unlovability defectiveness schema that, oh, I am so unlovable. Okay, maybe through my childhood experiences of, let's say, rejection, criticality, or certain negative experiences, maybe I have learned that I am unlovable. Nobody loves me, right? And I depending upon my temperament or depending upon what I have observed and depending upon a lot of other developmental factors, the individual is using a particular schema, a particular coping mechanism in order to deal with the pain of that schema. Because whenever that schema will get activated, unlovability schema, whenever that or whatever schema, whenever it will get activated, it is going to lead to emotional pain. And I don't want to feel that pain. I don't want to feel unlovable, right? So I will have to do something to avoid that pain. And that is what coping mechanisms do. They help us remove that pain, either by surrendering. Now, some of you will think, why is surrendering helping in avoiding pain? In what way is surrendering helping? Surrender to हम मतलब उस pain को मान रहे हैं ना? How is that helping? Any guesses? Why do you think surrendering is helping in avoiding the pain? It leads to acceptance. And what will happen if I accept? The cognitive dissonance will be dealt with, is what you're trying to say, right? So giving up is such a relief, no? Right? हाँ, अब मुझे इसके बारे में कुछ करना नहीं पड़ेगा. That is the relief that it brings, okay? And we'll also see how these different coping mechanisms, how they end up maintaining. So this maintaining is, in schema therapy terms, is called schema perpetuation. मतलब वो perpetuate हो रहा है. It is staying where it is, right? The coping mechanism is trying to do everything for me to avoid that, but it is ending up making it stay. So coping mechanisms, like we discussed, help in alleviating the pain of the schema to some degree, but they actually end up maintaining the schema. However, because they're reducing the pain that is caused due to the activation of the schema is maintained, isn't it? So the pain is reduced, but no deeper healing has happened. It is not like some in-depth reflection has happened that why do I feel like this? Where did this inference come from? None of that is happening with coping mechanisms. I am just, for now, for example, I have an exam tomorrow and I'm feeling very anxious and I start scrolling reels. So temporarily, I am not having to think about the exam, but the exam is still there. Now let us take, by means of these examples, we will try to understand how for the same schema, when different coping mechanisms are being used, how the behavior, thinking, the narrative is changing. Now let us say somebody has got a failure schema and some kind of a failure happens. Let's say they gave a job interview and they were not selected. So what will happen? The schema will get activated or will it not get activated? It will get activated, right? And it is not like our schemas are always active. They are there, but when something resonates with that schema, that is when it gets activated. Okay, and all of us have schemas. So suppose a person has got a failure schema and some kind of a real or imaginary failure happens. Okay, why am I using the term real or imaginary failure? Because in some situations, objectively there is failure is not happening. But subjectively it is feeling like a failure, right? For example, for some children, if they don't rank first, they feel like a failure. कि second कोई rank होता है, first ही तो rank है, right? So the schema is getting activated. Now this person tends to surrender to the schema. That is the coping mechanism, let's say, that they have. What is it going to look like? They will do tasks half-heartedly. What is the point of studying? I'm anyway going to fail. So they have surrendered. They have believed the schema to be true. They have given in to the schema. So they are doing the tasks anyway half-heartedly. What is the point? Kya fayda? No, that kind of a kya fayda thought process. What is going to be the outcome? They are inevitably going to fail. And the schema is maintained. See, I told you, I am a failure. I am going to fail. So this is how the surrendering helped in ultimately maintaining the schema. And the schema is being maintained. So now the schema continues to feel true that this is the narrative of my life. This is who I am. Now let us see. Surrender में तो समझ में आता है that I have surrendered, so it is naturally going to be maintained. How in avoidance and also in overcompensator, how it is maintained. So let us say, again, failure schema, that I am a failure and the event has happened, schema has got activated. Now I have a tendency, let's say, to use schema avoidance. I, let's say, have a coping mechanism of schema avoidance. What will I do? I will start avoiding, procrastinating work. Okay, because I want to reduce the pain of the schema by avoiding, by flight mechanism. So what will I start doing? I will procrastinate, I will avoid, kal kar lenge, kal kar lenge. The other person with the surrender, he is not saying kal kar lenge. He is doing it, but he is doing it half-heartedly, already knowing that I am going to fail. So what is the point? But this person is avoiding. They want to avoid the pain because if I fail, it is going to be too much. So they want to avoid. They're procrastinating. Now with procrastination also, what is the outcome going to be? They're going to fail, right? What else will it lead to? Ultimately, what is happening to the schema? The schema is maintained. The pain is avoided temporarily. I'm scrolling reels. I am maybe sleeping. I'm sitting. Then man nahi kar raha. Those kind of things are happening. Ultimately, what will happen? I will fail and schema will be maintained. Now, in overcompensation, why is it maintained in overcompensation? Overcompensation mein to we should have fought the schema and like had a different outcome. But unfortunately, that's not the story. Again, let's say some failure happened, schema has got activated. Now the person is using schema overcompensation. They want to overcompensate. They don't want this thing to be true. What are they going to do? Overachievement, workaholism, constantly comparing self with others, always ready for action. What is the outcome going to be? They're going to burn out, they're going to be exhausted, or they're constantly comparing themselves with others. Somebody or the other will be better than them, isn't it? It is not possible that you are the best at everything. So somebody or the other will be better. Somebody is getting promoted earlier, somebody is getting a salary hike, somebody is getting a 5% hike, I am only getting a 3% hike. So that constant mental comparison is happening. So the schema is still maintained, and schemas have this amazing way of maintaining themselves. Okay, because schema change is painful, unfortunately. It requires us to take accountability, to reflect, to go down into our childhood, acknowledge the pain process. So it is a much safer thing for the schema to be maintained. It maintains homeostasis inside our system. Now, similarly, let's say somebody has got a social isolation schema that I don't belong. Okay, I don't fit in, I don't belong. And they are using a surrender coping mechanism. Schema is getting activated, they are surrendering, they have a tendency to surrender to the schema. So what are they doing? They're already assuming, they're entering social contexts with the pre-decided assumption that everybody is different. I am anyway not going to fit in. तो वो पहले ही थोड़ा aloof aloof है. They are anyway looking at the differences. So they are already surrendering. They are already giving in. Feeling isolated, right? What else the outcome will be? Because I have already assumed that all of you are different. All of you will not be able to understand what I am saying, right? If I am already entering with that assumption, naturally it is going to be maintained, right? Now in social isolation schema, if somebody is using avoidance, schema getting activated, tendency to avoid, they will avoid. They will not meet people. They will isolate themselves. They will not take phone calls. Friends are saying, hey, let's catch up. Let's go out for coffee. No, I'm very busy. I can't come. Schema is making them avoid. Now, of course, if they are avoiding, they are naturally going to feel isolated because कोई पीछे तो पड़ नहीं जाएगा. No, 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 you have to come. You have to come. No, that's not going to happen. They are going to ultimately feel isolated. Schema is maintained. Now, what is happening with the one who is overcompensating, always ready to go out, always having FOMO, सब जगह पहले पहले जाना है मुझे. So their schema is getting activated, they're overcompensating. They're trying too hard to fit it. They're too afraid of missing out. And in the process, they lose themselves. Who am I? Who is my identity? I don't know who I am anymore. Because when I'm going out with Parul, I'm doing things that Parul likes. When I'm going out with Savita, I'm doing things that Savita likes. I'm going out with Rashmi, I'm doing things that Rashmi likes. But what does Priya like? Priya doesn't know that. So the outcome is I may come across very clingy. I might not be liked by people. People may see me as a very shallow person, isn't it? And therefore, ultimately, my schema is going to be maintained. All right. So are we clear with schema perpetuation? Yeah. Does it make sense? All right. Great. Now let's understand what is, yes. We'll probably come to questions later. Yeah. Maybe you can.
He may use different schema mode.
See, coping mechanisms are a broader term. Okay. There are different coping modes under each coping category. So for example, if I'm talking about, let's say, an avoidant style, right? There are different avoidant modes. For example, detached protector, detached self-soother, and a person can have different styles also. That let us say in professional world, my style is overcompensation, and in personal world, my style is surrendering, or my way of dealing with it is avoiding. So there can be permutation combinations. It is not like everywhere only one style will be used. There can be differences also, or maybe their first go-to is overcompensation, but when that doesn't happen, then they fully move to the other extreme of surrendering. So we will have to see. There are questionnaires that we use. There is a schema mode inventory that we use in order to understand the different modes we formulate, we psychoeducate. So it is not like one person will have only one coping mechanism. They may have different coping styles, different coping modes, different schema modes. And depending upon what we are seeing, we will be tailoring our approach to that person to holistically address what they are bringing to the session. Yeah. So chair work is one of the experiential techniques that we use in schema therapy. There are a bunch of other techniques, like there is imagery rescripting, there are flashcards, and there is other behavioral pattern breaking, etc. that we do. Chair work is one of the ways. So chair work to deal with coping modes. Now, why chair work? Why not something else? Why are we calling it chair work is also something which we'll understand. So why chair work? The purpose is to activate the emotions connected to the coping style. Now, let us say if somebody is using procrastination, if somebody is procrastinating, and if I as a therapist tell them, आपको procrastinate नहीं करना चाहिए, आप करिए, आप start तो करिए. I am not doing any favor to them by saying this because they already know that. Isn't it? What is happening underneath that? What is stopping them? Okay. Plus, let's also understand that they have a strong inner critic. They also will have strong punitive modes, okay? Strong punitive voices inside their head that I have to, if I do it, I have to do it perfectly. Otherwise, it is good for nothing. So in order to deal with this conflict, in order to deal with this pain, they are probably avoiding, okay? So we don't want them to feel ashamed. The whole premise of schema therapy, like we said, it is based on attachment. And we cannot really do justice without being, if we are not compassionate, okay? If we are not compassionate towards the parts, like Prerna said, that it is not like the mode is bad. It is not about good or bad. Why we are calling it maladaptive is because now it is not of any use, right? Let's say when we were small, we used to, our parents probably made us wear shoes which had those pee 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 sounds, right? Why? Because it reinforces walking. When the child is walking, taking baby steps, it is beep 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 beep, that kind of sound, and the child is feeling excited. But do we wear those now? Imagine how funny it would sound if we are wearing those shoes now. Because uska kaam ho gaya hai. Now it is not of any use. If we are using that now, that is maladaptive. Okay. So the idea is to bring it to the fore, to highlight what is happening, And we have to activate the emotions connected to the coping style, activate the emotions connected to the schema. And chair work also helps to reparent the patient in order to heal those emotions. We have to heal those emotions. We don't have to judge them by saying that, why are you already making these assumptions that people don't love you? Why don't you try? Why don't you do this? We have to heal. There is something happening underneath which has to be healed. And if yesterday some of you attended the session, we were talking a lot about limited reparenting. So we have to reparent them. And we have to meet their unmet emotional needs, and none of that is going to happen if we are lecturing them about aisa karna chahiye, aisa nahi karna chahiye. It won't happen. Shame will kick in, and shame is a very powerful emotion. It stops us from reflecting. It makes us defensive or makes us fully withdraw. And in either of the cases, if I have withdrawn or I have become defensive, what healing is going to happen? It's not going to happen. I'm just going to feel bad about myself. Okay, so we need to provide a corrective emotional experience, and we have to bypass the coping mechanism in order to work with the core inner child. The core, we call that the vulnerable child mode, or we can in in simple terms, we can call it inner child. We have to reach the inner child because all the pain, all the unmet emotional needs are there with the inner child. And to reach the inner child, I have to bypass the coping mechanism, because the coping mechanisms are like a shield. I'm wearing a shield. Koi mere paas mat aao. Nobody see my vulnerability. I have a failure schema inside and I don't want people to know that. So I'm going to avoid. मैं करूँगा ही नहीं तो fail ही नहीं होऊंगा. Right? So we have to bypass that barrier. And all of this has to be done without making them feel ashamed. We don't want them to feel horrible about themselves. They're already feeling bad. It is not like somebody who procrastinates doesn't know that they are procrastinating. They know that and they're feeling bad about it anyway. We don't want them to feel worse. Now, how is chair work done? The first stage is we will interview the coping mode. Okay. So we are going to personify the coping mode as if it is another human being. All right. Now let's say the client's name is, let's say, Rashmi, and Rashmi has a detached protector coping mode. Okay, detached protector falls under the category of avoidant style. Rashmi has a Okay, let's say Rashmi has a detached self-soother coping mode, wherein Rashmi uses binge eating in order to help with her emotional pain. Okay, let's say she feels very anxious, and whenever she feels anxious, she has the need or the urge to go and grab maybe a tub of ice cream. Okay, and that is Rashmi's coping style, let's say. So I will not tell Rashmi, you shouldn't be having so many ice creams. It's not good for your health. No, Rashmi already knows that she shouldn't be having so many ice creams. So Rashmi and I will collaboratively, I will, let's say I am doing schema therapy with Rashmi. So I will tell Rashmi that, Rashmi, from the formulation, which mode do you think, which part, or which coping mechanism do you think is getting activated? And Rashmi and I, let's say, collaboratively decide or conclude that, Dr. Priya, I think it is my detached self-soother. What makes you say that, Rashmi, that it is your detached self-soother? Because, Dr. Priya, it helps to soothe me. I detach from my pain and it helps to soothe me, because temporarily when I'm eating the ice creams, for that much time, I don't have to really think about the pain. Okay. Can we put this part on a chair, Rashmi? So when I say, can we put this part on a chair, the part is not an object. So basically, I will make Rashmi sit on another chair. And when Rashmi sits on another chair, Rashmi is going to pretend to be the detached self-soother. Okay, so I am going to interview the coping mode. Why are we doing this? Why are we talking to the mode? Why are we not talking about the mode? Any guesses? Absolutely. Yes, absolutely. Thank you for saying this. So the whole idea is to activate the emotion. Okay, so one is it is going to activate the feeling part. Second is that it is also going to take away the shame. Now the mode is another person. Okay, right? And then we interview the coping mode. And what we do when we interview, we'll talk about it. So the goal is to bring into awareness of the mode, to bring client into awareness of the mode. I want to make the client aware of the mode, that there is this mode, there is this coping mechanism, and learning more about that particular coping part through interview. So I want to learn about it. That's where compassion is kicking in. I want to understand, curiosity, right? I'm being curious about it. And finally, the second stage is to bypass it. So I'm going to elaborate upon both these stages. And the stage 2 goal of bypassing the coping mode is we have to agree on limiting the mode in the session and outside the session. So in stage 1, we will activate the mode. We will externalize it by making it sit on another chair. So usually, if I'm doing an online session, I may ask the client to have another chair, maybe either on their right side or on the left side, and they will sit on the other chair, because I don't want Rashmi to be fused with the mode. I want the mode to be for Rashmi also to understand that you are not your mode. This is a part of you, right? You are not binge eating, Rashmi. Binge eating is a coping part of you, and it is separate from you. Your identity and the part is different. Okay. So we externalize it by making it sit on a different chair. That let's say Rashmi has a chair on her right side, and I make the coping mechanism or the coping part. I make Rashmi sit on the right side. And when Rashmi sits on the right side, Rashmi is that detached self-soother part. Or we can also sometimes collaboratively come up with innovative names. My ice cream eating part, or my reel scrolling part, or my something, whatever. Or the client may come up with names from maybe a fictional character or something. My superhero part, my I have to rescue everybody part, something like that. Okay, so we externalize it by making it sit on a different chair, and then we interview the mode. And in this interview is where we are sort of, because when I'm interviewing, Rashmi's neural networks are getting activated. Okay, Rashmi is now having to think where this mode came from, what is it doing, etc., etc. So I first try to understand the goal of the mode. Okay, so we greet the mode. Hello, detached self. Hello, Rashmi's detached self-soother. Thank you for agreeing to talk to me. Okay, so I greet the part, I welcome it warmly. And it is again done with compassion. We don't have to be strict and punitive towards the part. तुमने रश्मि की जिंदगी मुश्किल करके रखी हुई है. No, we are very compassionate. We understand. Okay. Hello, Rashmi's detached self-soother. Thank you for agreeing to talk to me. Rashmi and I have been discussing about you, and I would like to understand from you, when did you come into Rashmi's life? So now I want to know what was happening in Rashmi's life that Rashmi had to fall back on this. And then Rashmi from the detached self-soother part will probably tell me that I came into Rashmi's life when I'm not able to exactly say, but maybe when she was about 10 years old. Okay. And what was happening in her life around that time? So now I want to know that what was the crisis that at that time Rashmi's parents were undergoing a divorce, and it was a very difficult time for Rashmi. So they would usually keep ice cream at home. And when we are talking, when I am externalizing the part and making it sit on a chair, I am talking to the part, Rashmi is talking from the part, and the part and I are talking about Rashmi. So we are talking about Rashmi in third person. Okay, that Rashmi's parents were undergoing a divorce, and it was a very difficult time for Rashmi. So she didn't really know how else to make herself feel better. So sometimes on her way back home from school, her mom would buy her ice creams, and Rashmi would feel good. And that is how it all started. And sometimes they also used to have ice cream tubs at home. So whenever Rashmi would feel overwhelmed, her mother would say that maybe Rashmi have something sweet, tumko acha lagega. Or Rashmi herself discovered that when she feels sweet, at least for that time, she feels good. So that is how it started. So we understand the goal. Okay, so Rashmi's detached self-soother, what were you trying to protect her from? I was trying to protect her from anxiety. So now we know that why the coping mechanism is still there. All right, and how are you trying to protect her now? What are the functions that you are serving now? That even now, when Rashmi feels anxious, um, I tell her that maybe having an ice cream will make her feel better. Okay. So I understand the goal of that mode. History, survival needs, and then we identify the pros and cons. Now, to identify the pros and cons, the mode will most likely be able to tell us the pros. The mode will be able to tell us how they are helping, why is it useful, what is it doing, etc., etc. The cons, the mode might not objectively able to tell because the mode is there to help. Okay. So but we also want to know the cons. Pros to already pata hai. What are the cons? Because we want to bypass it, right? We don't want Rashmi to deal with her anxiety like this. We want Rashmi to develop better coping mechanisms to deal with her anxiety. So then we make her change chairs, okay? So Rashmi was sitting, let's say, on the chair on the right. Now we make Rashmi sit on the original chair where Rashmi was already sitting, okay? And when Rashmi is sitting there, I can invite the healthy adult part of Rashmi. That healthy adult Rashmi, we just heard detached self-soother Rashmi talking about how she helps her, etc., etc. And she has done a fairly good job of protecting Rashmi from anxiety. But what do you think? Now we want to activate the healthy adult neural network. Okay, what do you think about it? And then the healthy adult may say, but yeah, I feel horrible about having so many ice creams and it just doesn't feel right. I feel bloated, I feel unhealthy, I'm putting on weight. Yes, the anxiety does get reduced, but that's not how I like. That's not what I like. That's not who I want to be. You know, and Rashmi says that. Okay. Rashmi, do you want to say something to the detached self-soother part? Okay, so that's again something that we do. We validate the role that the coping mode has played in protecting the client in the past, but we also want to change. Then the healthy adult Rashmi looks at the chair on the right and says that, hey, detached self-soother, I really value what you bring, but then I don't like it. And this is not who I like to be. I want to eat healthy and it doesn't really sit with my health goals. I feel very bad. All right, Rashmi. So you were able to talk to the mode. And then we, as a therapist, will again look on the chair in the right, and Rashmi will keep sitting on the healthy adult chair. And now I will talk to the mode that in a very compassionate way. That detached self-soother, Rashmi, thank you for sharing all the insights. And I can see how you have really helped Rashmi when Rashmi was undergoing all the crises during childhood and even now. But then you know what? As healthy adult Rashmi has also shared, it she doesn't really align with this. And would it be okay for you to sometimes allow healthy adult Rashmi to take charge? Would it be okay for you to maybe just reduce a bit and not come up as often? Okay. So this is what we do. And then we wind up by telling healthy adult Rashmi to be mindful when the detached self-soother part is coming up. Okay. We take the we take the takeaways from the client. What do you understand? What did you understand? How did it feel? And usually clients will say, it felt very insightful. मैंने तो ऐसे पहले कभी सोचा ही नहीं था. I just didn't know. It just felt nice and I was doing it and then feeling bad about it. So that is how chair work helps. I don't know, ma'am, if we have time, would it be okay if I do a demonstration or? Yes, only if we have like another maybe 6-7 minutes. We do? All right. So we will have to do a little bit of movement over here and I can be the therapist. And if somebody wants to volunteer to be a client, and we will try to be a less complicated client because we are just demonstrating a skill, right? So anyone would like to volunteer to be a client and we can like talk for 2 minutes, decide what we will demonstrate? Okay. All right. Okay, come. If you'd like to introduce yourself.
Sure. I'm Akanksha and I'm a clinical psychologist. I've been practicing for a long time. And just for a context is I've trained in EFT. It's similar to chair work, but still different. So I thought I'd, come up for the demonstration.
Amazing. All right. So what we will do is we will keep the EFT trained Akanksha in that chair. Okay. Thank you. All right. Okay. So we'll need to have 3 chairs, one for me, 2 for Akanksha. and we'll need to have a hand mic for both of us. Yeah.
Okay, so you can start by sitting on this chair and then you can shift to that one when you're the cooking basket.
All right, are both of us visible to everybody? Okay. Hi, Akanksha. How have you been? Yeah, just tap on it.
Yeah. Hi, I've been good. Been thinking about a lot of things lately. So yes.
And maybe is there something that you'd like to share with us, like share with me? Maybe something that my mic, it seems to be echoing. There's some kind of an echo that's happening. Hello. Hello. Yeah, this is it. Still echoing. I'll keep it a little far. Okay, Akanksha. So in our sessions, you have been talking about how you are very keen on taking up trainings and training programs, but we've also been discussing about some inhibitions, and maybe today we could spend some time talking about those inhibitions and maybe do some experiential work with that part, if that's okay
Absolutely.
with you.
Yes, sure.
Yeah.
Yeah.
All right. Do you want to maybe talk a little bit about what comes up?
Right. So to give a context is being in the field, being trained for a couple of years, working for multiple years, people believe that you should have an idea, right, of the topics of the field. But when I'm in training, what I see is I'm very restrictive. I wouldn't ask questions immediately because then I'm like, oh, I feel stupid if I ask a question, right? मतलब इतना तो पता होना चाहिए if you're in the field for say maybe a decade or so. So why would you ask a question? Even if it's a very new topic for me, I'd have a lot of overthinking on, oh, don't ask, contemplate. And if somebody's asked it, I'm more than happy. It's been answered.
That's like a weight lifted off your shoulders.
Absolutely. Yes.
Right.
Yeah.
Right.
Totally.
Okay, Akanksha, but does it concern you? Like,
Yeah, because I'm not like this outside.
Okay.
In any other domain of my life, I wouldn't restrict, I wouldn't hesitate. I'm not judging my abilities. But when it comes to professional area, no matter how confident I am internally, verbally, I wouldn't, put up the question or just speak it up. Yeah.
Right. So, Akanksha, as we have discussed in our earlier sessions, we have a schema formulation that we
Yes.
have done, right? And it does seem like an avoidant coping mode that seems to be coming up, right? Possibly an avoidant protector protects you by avoiding.
Looks like.
Yeah, right. And would you be open to doing a chair work practice with me, maybe so that we can understand this part better and we can see what exactly is going on? Would that be fine, Akanksha?
Absolutely. Yeah.
All right, Akanksha. So what I would request you to do is, I would request you to put that part on that chair. So when I say put the part on the chair, I would request you
to sit on that chair
Yes.
and be Akanksha's avoidant protector.
That voice.
Yeah, that particular voice, no, which is saying that, oh, don't ask any questions, Akanksha.
Right.
Right? So we'll put the avoidant protector on that chair.
Sure.
And when you go and sit on that chair, I would request you to talk from the avoidant protector.
Okay.
And I will be talking to the avoidant protector and we will be talking about Akanksha.
So I'll be talking to you still.
Yes, you will still
I
be.
won't
Yes,
be talking
yes,
to.
yes, absolutely.
I'll
Yeah,
switch.
yeah,
Sure.
please. Sure. Thank you, Akanksha.
Okay.
Okay, Akanksha's avoidant protector. Firstly, thank you for agreeing to talk to me.
Sure.
Yeah.
Doesn't feel good, but okay.
Okay. All right. All right. Yeah. So you're really, Akanksha and I were just talking about how you show up during, let's say, seminars, conferences where Akanksha wants to ask questions, but then you sort
Stop
of,
her.
yeah, stop her.
Yes.
Right? I'm curious to understand, avoidant protector, when did you come into Akanksha's life?
I've always been with her.
Okay.
Yeah, I think, I mean, not like I know a specific time, but I think school days.
Okay.
Yeah.
Early school days.
I don't
or
remember
maybe
not.
teenage. Okay.
I don't remember not being with her.
All right. So you like almost have been there.
Yeah, any academic, yeah, any academic thing or work related, but I've always been
Okay.
inside of her.
All right. And do you has there been any particular incident, let's say during her school time or something, where you like really became strong, or there was like really that need for you to take over?
I think multiple such times which I knew were not subtle. They were very important because people around her would ask questions in a very articulate way. She'd want to do it, but she would not articulate it well. And then she'd be very critical. कि मैंने क्यों नहीं ठीक से frame किया. So then it was best कि मत पूछो. Like
Right.
when you
right,
don't
right.
frame it well, and if you judge yourself for that, then don't ask the question only.
So you are, in a way, protecting her not just from external criticism, but also
yeah.
from internal criticism.
Yeah, absolutely. I'm
Right.
always criticizing her for that only, so that I can stop her from
Oh,
getting.
the critic is criticizing her. You are protecting her.
Yeah, from the
Yeah.
world
Right, right, right.
outside.
So there's also like a lot of protective function that you
Yeah.
bring.
Yeah, absolutely.
And in what other ways have you shown up in Akanksha's life? In what other ways have you sort of protected her?
I've tried to do that in a lot of other places with her, but she's able to like stop me.
Okay.
Matlab, she's into a lot of other things. She has multiple hobbies. She's very social, so she doesn't let me come up there.
Right.
She's not bothered ki how I'm coming across there.
Right.
Am I looking confident? Am I articulate? So then I don't have to
Right. So
kind of save
places
her.
where Akanksha is able to manage, you're not really
Yeah, where I'm
needing to
doubly
jump in.
sure.
Right.
Where I'm
right.
doubly sure that she's not going to turn around and judge, अरे ऐसे पूछना था, वैसा बोलना था. Then,
But when there's
otherwise,
some degree of unsurety is when
even
you really need to jump in.
I will.
Right. So
Yes.
there's definitely a lot of protective function that is
Right.
happening over
Over
here.
here. Yes.
Right. All right. Anything else, avoidant protector, that you would like to share, which might give us more insight? Like you said that, you've like pretty much always been there. Have there been, let's say, a very big incident which has ended up reinforcing you that, Dikha, thank God I didn't.
Yeah, multiple times. I think initially when she went for a lot of conferences and seminars, it happened. तब 100-200 लोगों के बीच में, she'd ask. वो question answer होता था, but it would not feel it's answered the way she wanted it. So then she'd sit and then she'd crib the whole way through it. So gone the topic, gone the speaker, she's not listening, she's in her own head there.
Right.
So then I'm like, but you're here for the topic, right? Like, let's leave it. Matlab, mat pucho, but then the whole day is gone. Everything after that is literally spoiled. So then she's in a spiral of judging everything about her.
Right. So again, you come handy that, see, we shouldn't ask
We shouldn't
only.
ask.
Right.
Yeah,
right.
there's absolutely no.
Right.
And she doesn't listen.
the problem is that, like, if I tell her once, she won't listen. So I have to keep coming back.
Keep coming back.
And be louder and
Ah.
harsher. That you got to listen to me when I tell you the first time. So I'm very dominating in the head.
So then you have to like really occupy a lot
I'm
of
sitting on her head.
space and make sure that Akanksha like really listens
Why
to
you're
you.
not listening? Yes.
Right.
Yeah.
Okay, avoidant protector. So I can see that, you have, of course, in a lot of ways tried to protect Akanksha, save her from potential embarrassment, I would say.
Yes.
Yeah.
Totally.
Okay. I would request you to go back to that chair and we'll hear from Akanksha's healthy adult.
Right.
Okay. So Akanksha, we were just talking, I was just talking to avoidant protector Akanksha, and you also got the opportunity to listen to what she was saying, right? So she said that she's been there with you pretty much all the time, and especially during conferences, she gets really activated.
Right.
Okay. She does say that there are pros to it. But what do you think about it? What do you think is really happening for you as healthy adult Akanksha?
I hate her.
Okay.
Yeah. That's the person I don't want to see. That's
all
the person I
right.
don't want to be for anybody.
Okay.
So when I'm that person to myself, I despise her.
Right.
So every time I see her come, I go into my shell. कि
Right.
अरे फिर से कुछ गलत बोल दिया, सही से नहीं बोला. So I don't want to see her
Right.
at all.
Right.
Yeah, it doesn't help. Like she
Okay.
said all that she said, but I don't think
But ultimately, it doesn't help.
it doesn't help.
Yeah. And in what ways does it not help? I understand that you have very strong feelings
It makes me
against
doubt
her.
myself.
Okay. So
It-
there's self-doubt.
Yeah,
Right.
it makes me critical. It makes me judge my expertise. It makes me
Right.
question my skill
Okay.
as a therapist, because it's mostly in a professional space, right? It's not otherwise. So then there's a whole disparity कि बाकी सब चीजों में I'm excelling.
Right. So
And in this, even if I have the
there's a lot of
caliber,
dissonance.
yeah, which the world is telling. Like I hear everybody across my journey saying a lot of good things about me and my work, but I can't believe it because she doesn't let me believe it or hold on
It's
to
such a
it.
difficult experience, Akanksha.
Yeah.
I'm also wondering, I mean, this is just something that came to my mind. She probably, do you think she also stops you from learning, or maybe you have a genuine question and she
Yeah.
doesn't really
Yeah.
allow you?
Then I don't know the answer, right? Nobody asked and I didn't ask. तो मैंने सीखा नहीं, तो I went back with that doubt, and I don't know when I get clarified with that doubt. So I don't grow, I don't learn.
Right.
So,
Akanksha, while I see that you have really strong feelings for avoidant protector Akanksha, and I see where those feelings are coming from.
Right.
However, I would also, request you to maybe have little bit of compassion. I know this is difficult. I know what I'm saying is tough because I can see why those negative feelings are there. But from a schema therapy perspective, Akanksha, that part, like avoidant protector said that she has always been there with you. Maybe some chote mein kuch hua hoga, which maybe is not there in your semantic verbal memory anymore.
Yes.
Okay, or maybe through some observation, whatever, through whatever means.
Right.
But there was probably some
need
utility,
for it to
some need, or some
Absolutely.
utility as well.
Yeah.
Okay. While I know that there are these really, really strong emotions, okay, but the ultimate goal that you want is you don't want her to be like really encompassing you.
Yes.
Would you want to try to compassionately say something to her? And maybe you can look at her as you say that.
Is it okay if I don't look at her?
That's your choice. I respect that.
Okay. Maybe to tell her compassionately is I don't mind her coming, making me, pause for a moment, making me gauge the situation better, but she can be softer.
Okay.
She can be less critical. She can exist with me
Okay.
and make me do what she wants me to do, but in maybe a little less harsher, critical way. So if she can do that, I'm fine.
Okay.
But unless and until she does that, I don't want to look at her.
Okay.
Yeah.
All right. All right. I can see that there's still a lot of
strong.
I really wish she
Yeah,
becomes lesser
yeah,
because I know I can excel if.
But I would really commend you that in spite of having really strong negative feelings for that part, you were at least able to sort of bring in some compassion. Yeah.
Yeah.
Would it be okay, Akanksha, if I say a few words to avoidant
Sure.
protector Akanksha?
Yes.
Yes.
Absolutely.
Okay, so now I'm not going to make her sit again. We're just going to imagine that part and we're just going to have healthy adult with me on board. Avoidant protector Akanksha, I really see that you are very strongly intending to protect Akanksha from any kind of embarrassment by stopping her from asking questions. But you know what? While I see what you're trying to do, I would also like to say that you are in a way stopping Akanksha from growing. She's attending all these conferences, seminars, training programs for learning, right? So would it be okay for you to trust? I would really want you to trust healthy adult Akanksha and not show up as much. And I would want you to not show up as often. How does that sound?
Sounds okay.
Sounds okay.
As long as she can do it.
Yeah, yeah, all right. How does it feel to have done this exercise, Akanksha?
Feels like there's a way, there's like a block which has some door to it, which I didn't have or I could not connect with. So, like that dialogue tells me that I can always turn around and tell that, this is what we discussed.
Right.
That you won't do this or this is how you'd be. So, there's that healthy connection that I feel
Is established.
which I think till date I didn't have. It was always, let's run from each other. Let's not sit together to figure out a midway.
Right,
So yeah,
right,
that for
right.
sure.
Yes,
Definitely
and-
feels lighter. I know
Mm.
those are things, like you were saying earlier. I always knew she comes from a protective place, not like I didn't know, but it just feels that, okay,
But
that
it's overprotection, no? Yeah.
Yeah. So I have a voice and I can
Yeah.
kind of be assertive towards her. Yeah.
All right, Akanksha. So one thing maybe you could do outside the sessions is when you see avoidant protector Akanksha coming up, maybe just be mindful and gently giving yourself a reminder that this is my avoidant protector part that is coming up.
Yeah.
And maybe you could also do a behavioral experiment of trying to ask the question nevertheless.
Yeah.
And we can see, right?
How
Because
that
sometimes
goes.
our coping parts also need to experience
Absolutely.
what exactly will happen if we don't use that coping part. It may
Yeah.
not happen right away, but in safer situations, maybe in smaller gatherings, in
Right.
smaller breakout rooms, let's
Lesser
say,
intense.
if you are doing an online training in smaller breakout rooms
Sure.
or in smaller, safer places, you can try to behaviorally see what
Like what's
happens if I don't do what she's asking.
Surely.
Yeah.
Yes. Sounds good.
All right. Thank you so much, Akanksha, for being such a sport. Thank you. You've done a great job. All right. Any questions from what we did? Yes.
Especially. Thank you. So my question is, in my 5 years of practice, what I have been, or what I used to do earlier is, I
reading that, see, why schema therapy came was because some of the more top-down approaches like CBT, they were lacking in these things. Schema therapy, you will see there's a lot of overlap with CBT, right? But it goes little bit forward. So when you are seeing that there is resistance and you are trying these behavioral methods, but it is not happening, that is when you can isolatedly take up a technique from schema therapy and use, or if one wants, they can also get formally trained in schema therapy, right? And see, the top-down approaches or the talking and etc., it will help. It is not like, see, when all these more bottom-up approaches or integrated approaches were not there, it is not like therapists were not being able to help people. तब भी therapy होती थी, तब भी there were RCTs happening, RCTs were showing improvement, all of that was still happening, okay? But the idea is not just to resolve symptoms. It is not just about symptom resolution. It is about healing patterns. It is more about in-depth healing. And that is where these kind of techniques, these kind of methods come handy. Because, see, had it, let us say, so Akanksha herself is a therapist. So some internal reflection she already does with herself. But if we were doing it with a client, the client is not a therapist. With them, so much more material will come that when I was 5 years old, this happened, and then I decided, and at that time, etc., etc. Okay. So with a client, much more clinical material, much more unhealed stuff will come, isn't it? Plus, see, with a client, the therapy is happening in a private room. So they are more open to sharing stuff than when we are doing demos, when we are, everybody is, 50 people are observing and 2 people are talking. So of course, some little bit of diluting will happen. Okay. So these kind of techniques are very useful when we are working with clients with whom, in spite of so much work, that pattern is just not resolving. So we put that pattern or that coping mechanism on a chair, we talk to it, we try to understand where it is coming from, etc. So that's a very, really elaborate, in-depth thing that we do.
And just one extension question to this. As you said, is there any research which proves that, for example, when the same thing was resolved using CBT and it was, let's say, resolved for at least those 6 months, the client was terminated, and when it was resolved using chair work, is there any research which shows that in a longer run, like 5 years, 10 years, 15 years, which proved to be a better, where there is lesser chance of relapse? Any such researches so
So
far?
I think I will have to do little more upskilling and reading about it. Okay. But if I come across such papers, I will definitely maybe share. And but see, one thing, you're talking about it longitudinally. Schema therapy is not that old that we will have studies which are like 10 years, 15 years down the line. The earlier studies of schema therapy, if you see the earlier papers, they were all about understanding about schemas, understanding about schema modes, understanding about the interaction between them. In this disorder, what modes are there? In that disorder, what modes are there? In forensic population, what modes are there? The research on the therapy per se is happening more and more now. So right now, as far as my understanding goes, I don't think we have that longitudinal studies. But of course, go to Google Scholar, find out. I'll also go to Google Scholar. I'll also try to find out. And if I find something, I'll share. Yeah. Thank you for your questions.
I firstly thank Dr. Priya ma'am and Prerna ma'am for such an enlightening presentation. I have 3 brief questions, ma'am. And the first one, because I take some basis in Gestalt school of thought, I wanted to ask, many a times when we try to do chair work, may it be because of hesitance, and even we could see Akanksha ma'am, say that she's not feeling comfortable at the moment. There might be resistance that comes up during such work. And usually in Gestalt, we try to go with experiments, and we try to go for exposure or something like that. But how do we deal with such resistance when it comes to schema therapy?
See, we need to understand that it's all about being compassionate and all about keeping the client's comfort in mind. So if there is resistance, it's schema therapy has got many experiential techniques. Like imagery is there, chair work is there, and then we also can become very innovative with how we are doing it. Okay, if there is resistance, we can explore what the resistance is about. Because if there is resistance, we will not be able to activate the emotions beneath the coping mechanism. We will not be able to reach the schema, right? So the resistance itself is a coping mechanism that is stopping us from going there. So we will have to explore, and we can put the resistance on the chair, and we can explore that resistant, let's say the client's name is Sudhir. So resistant Sudhir or resistant part of Sudhir, I would like to understand in what way are you helping, etc. So we are in no hurry to heal them, which is why schema therapy usually, yes, for research purposes, there are protocols that 20 session module, this many session, that many session, because research has to have some framework, right? We can't be going on and on and on. There has to be some module, some structure. Otherwise, how will we compare different clients? But in a clinical setup, it is not about rushing. It is not about hurrying. It is about being compassionate. It is about, it is not about my need that mujhe karna hai chair work, you have to agree. Okay, if you're not willing, we can explore, we can see. Sometimes there is also something called empathic confrontation. Like one of my clients, every time we would plan a therapy goal and we would decide that we will do imagery or something around it, the session in which we are supposed to do in that session, for some or the other reason, he will say, you know, Priya, today I'm having a headache. I think today we will not do. Maybe let us talk about this. Then, okay, fine, chalo. Next session. Priya, you know, today I'm just feeling too fatigued. I didn't have a good sleep. Can we do this next time? So 2-3 sessions tak ye continued. After that, I had to empathically confront. I had to very gently nudge him and say that, hey, look, you know, I can see that there seems to be a part which is stopping you from working on this particular memory. I know that this is a very distressing memory, and I see why you would feel resistant. But is it okay for us to just explore the resistance little bit, because it is not helping us move beyond that? And we can empathically confront that. I see that every time we are bringing up this particular memory, there is a part of you which wants to process it, because you are saying that you want to process it, but there's also a part which is stopping you from that. And is it okay for us to explore that a bit? Because I'm concerned that this memory is really bothering you. And then we explore the resistance. There may be shame, there may be guilt, there may be fear of being judged. Like clients who have, let's say, sexual experiences, sexual trauma, or some kind of sexual addictions, for example, pornography, etc. They are very resistant to do experiential work because they feel judged. You will see that they are looking away while they are talking about that thing. They are looking down when they are telling you about that thing. So we have to honor the resistance. The resistance also has a survival function. And we have to honor that, be compassionate towards that, and compassionately bypass it. Yeah, does it help?
Yeah, Priya, I think we have to wind
Yes.
up because I have another session.
Yes, yes, Dr. Maithili, thank you for the reminder.
I'm so happy that all of you are so serious and involved in this session. I believe she has done a marvelous work, both of you. Congratulations. Yeah. So, a lot of questions maybe, and you can meet her and maybe learn more, individually. What I have understood is that they have beautifully presented Prerna to begin with the base of what schema therapy is, what are the goals, and how schema therapy works. What is more important for me to understand, I made a lot of points here that how they are so integrative into psychodynamic attachment styles of Bowlby when we understand about the secure and insecure attachment styles. So that is also brought in anxious, avoidant, preoccupied, fearful, if we remember all those theories. Then again, the CBT model, when we talk about cognitive errors and defense mechanisms, right? So those also have come in. That is a coping mode that people are talking about, fight, flight, and freeze model. So we all had learned all those, remember, fight, flight, and freeze model. So those are basically the surrender and the detachment and the overcompensation that people do. So there's a lot of connection, but how the process goes, that is different. The theory is basically, definitely there are so many connections. So again, the emotional expression, which a lot of our clients do not have. Many a times you will see a lot of people don't know how to feel and how to emote. And maybe they don't know the thought and emotion and the behavior connection. So that becomes very difficult. So you have to really know whom you're going to apply schema therapy for, because it is very much tailor-made for personality disorder clients also. If you're talking about emotionally unstable personality disorder, as we say, borderline personality disorder. So there we have all these counter-transference experiences. So our own schema also comes in. So, what schema are we dealing with? What is the mode that we are dealing with the clients with? So those are again the transference and the counter-transference issues that Freud had rightly, brought in. So PD, you can work. I think a lot of PD cases you can work with because they are so much rooted in childhood experiences when we talk about personality disorder cases, right? So, and most of our clients, we have an access to disorders. With Access One, we have an access to more than 50 to 60% of the clients you'll be seeing in the clinical population. So maybe, a schema will work there. And there's this self-fulfilling prophecy that she's talked about. She had talked about, again, the modes, how the vicious cycle, the modes of coping modes as well as this schema being maintained, right? So that's again a vicious cycle. Then she also spoke about the unconscious self, then giving insight to our unconscious self, bringing and showing the conscious self. That's by how we heal that again, by the insightful method that she had used. So we have brought in again supportive psychotherapy here. So a lot of things came to my mind while we were talking about, she talked about the rejection, she talked about vigilance, and maybe about autonomy and power, how we lose ourselves to the modes. So we become fused, the fusion that happens between me, the self, and the modes of coping, right? And how we are detaching that, that is like how we talk to an alcoholic. We don't say he's an alcoholic. We say a person with alcohol use or a substance use. We say a person who is having binge eating problem, right? We don't say binge eater. So that is how we have to detach that mode from the person. So that is what she had tried it beautifully, and the person also had got into it. So I think a lot of learning from here. And there's an acceptance and commitment to therapy. If you're not committed and you're not saying that, okay, I'm going to do this and, I want to do this, that therapy is really not going to work. Okay. So I think they have done a very nice presentation, and a huge round of applause to both of them. Yeah. And thank you, all of you. I found a lot of curiosity, and at this hour also after lunch, you people want to learn so much. So that shows where psychology had gone. And all the best to all of you. Yeah. Thank you.
Thank you so much, ma'am, for all those insightful words and guiding us through this session. I would also like to extend my heartful gratitude to Dr. Priya and Ms. Srivastava for this amazing and insightful discussion. And during the demonstration, I was really actually feeling that my avoidant personality is actually talking out through it. So thank you everyone for being a patient audience. I would now like to call upon Dr. Hazarika to felicitate our speakers. We have more for you. I would now like to call upon Ms. Neha Das, Professor, Amit University, to kindly felicitate Dr. Hazarika. Thank you so much, everyone, for attending this event. You may please proceed to the other halls. There are academic sessions going on parallelly.